We are live.
Good morning, everyone. On behalf of AIOS, I'd like to extend a very warm welcome to all those in attendance to AIOS GuruSangam 2025 to 26 edition, session 13, Retina. Thank you for choosing to spend your time on this Sunday morning with us on this platform aimed to educate, elevate, and excel. On the outset, I would like to thank our AIOS dignitaries for conceptualizing this excellent academic initiative. Our President AIOS, Dr. Partha Biswas, Honorary General Secretary AIOS, Dr. Santosh Funawar, and Honorary Treasurer, Dr. Manoj Chandra Mathur. Thank you to our speakers for consenting to take part in today's discussion. Dr. Prateek Shah from Kiran Medical College, Alpur, Dr. Sonam Verma from Opal Eye Care and Laser Surgery Hospital, Indore, Dr. Shweta Walia from MGMMC, Indore, and Dr. Ashriya Karpe from Shroff Eye Center, New Delhi. I'd also like to extend our thanks to the expert panel who have heartily consented to take part in the discussion and extending their expertise and insight. Dr. Apurva Ayachit from Joshi Eye Institute, Hubli, Dr. Kurobi Lahiri from Bombay Hospital, Mumbai, Dr. Mona Bhende from Shankara Nethralaya, Chennai, and Dr. Prashant Bavankule from Sarakshi Nethralaya, Nagpur. Today's thoughtfully curated session will cover all the basic skills of retina examination. We'll start off with decoding skills of retina examination with indirect ophthalmoscope, followed by clinical fundus examination, fundus fluorescein angiography, and lastly, basics of OCT angiography. I will be co-moderating this session with Dr. Sameer Chaudhary from Aravind Eye Hospital and myself, Dr. Mahima Kaushal from Center for Sight, Hyderabad. Without further delay, I would like to invite Dr. Prateek Shah to start his talk on decoding skills with retina examination with indirect ophthalmoscope.
Hello, good morning. So, Mahima, will you please stop sharing?
Yes.
So, very good morning, all of you. And I'm thankful for having this topic because this topic is one of the very important topic. And from one of my very favorite topic, it was my first fellow presentation when I joined Shankar Nethralaya as a retina fellow. So, slide are moving.
No, sir, we are at the
Not yet.
introductory slides.
Actually, that
Yes.
slide control, I think you have to give me. Assign slide control privilege.
Just click on the screen. You should be able to continue this. Just click on the screen and you can do the slides.
Okay, sure. So
Yes, sir.
basically, first, now we will discuss about first why we were in need to learn this skill of the indirect ophthalmoscope. Most of the time, when we joined our ophthalmology residency initial period, we are very easily learning this direct ophthalmoscope and slit lamp biomicroscopy. Then, are we not adequate enough to do only with these skills, this set of these skills? Why specifically we need this indirect ophthalmoscope, which requires special training and constant practice? So yes, there is significant amount of the retina, which is like an anterior part, and this part of the retina is very difficult to examine with these instruments. So that is why we need indirect ophthalmoscope for the complete examination of the detail in peripheral retinal examination. Now, in order to see the retina that is beyond the equator, light must traverse obliquely through the cornea, lens, and vitreous. And because now this oblique pathway that will induce the cylindrical aberration, as well as this will increase the total number of the opacity that light has to traverse. So in this phenomena, there is significant amount of the amount of the high magnification induced aberration, and the illumination that are available with this direct ophthalmoscope of this retinal microscope are reduced. So to work on this, again, we need to have an indirect ophthalmoscope to have a complete examination. Again, one of the very key important point, that's a stereopsis. And to understand exactly whether it's a retinal hemorrhage or a retinal break, to show the differentiation of the elevation, this stereopsis is very important. That will be provided only with this indirect ophthalmoscope, not with the direct one. Now, the last but not least is a palpation of the fundus. With the help of the scleral indenter, we are able to get a dynamic examination of the retina. What exactly means when there is a retinal image, we are directly looking at it, that's a static. But with the help of the scleral indenter, we keep the moving of the inner coat of the eyeball, that's a sclera, and with that, like just we are palpating the sclera, and with the sclera palpation, we are actually having a feel of that palpation of the fundus. This is classical, known as a Brockhurst indication, and very well documented as useful in the retinoschisis and versus retinal detachment to differentiate this. Like for example, as we all know, retinal detachment is a case where the retina is little freely moving mobile thing along with the subretinal fluid. When we indent, this SRF can move from one place to other place, and retina can have a undulation and the folds. While in case of the schisis, when we indent the peripheral retina, this actually this elevation of the schisis is a dome shaped and tense membrane, which will move as a single unit when we indent. So that is how this dynamic phenomena or in the palpation of the fundus will again helpful to us. Now, why we call this skill as an indirect? Because in this, rather directly looking at the someone, we are looking at the image. Here, like for example, we are not directly looking at the observers, we are not looking at the subject's retina. We are creating an image of the subject's retina, and that image is in between the subject, or in between the condensing lens and the observer, and this image we are using, we are looking at. So we are not like directly looking at the retina, and that's why it is known as an indirect ophthalmoscope. Now, to understand, to be good with this instrument, there is one very mandatory thing that we know each and every part and how they functions very well. So let's discuss about different parts. So first and foremost is proper placement of this indirect ophthalmoscope, for which we are having the headband. This headband had a two screw tightening. One is at upper part, which will decide the depth of our head on which indirect ophthalmoscope will set in. And second is this of circumferential proper placement of the indirect ophthalmoscope. Apart from this, there is an illumination system. This illumination system is basically this part of this vertical placement. And here is with the help of this mirror, this light is reflected towards the subject's retina, which is going to be illuminated. Now, apart from this illumination, there is again the capturing system, which includes the placement of the prisms as well as the convex lenses. So basically, this is exactly how these are the prisms. And importance of this is that when the subject's retina is illuminated, image is created with the help of the condensing lens. And now this image has to be seen by the observer with both eyes. So with the help of these prisms, we divide this image, which is generally coming at a 15 millimeter distance to the subject's IPD, interpupillar distance, that's around 65 millimeter placement. So importance of this prism is to convert this distance from the 15 millimeter to 65 millimeter, or whatever the subject observers interpupillar distance. And there is a condensing lens, there is a plus 1.5 or 2 dioptric convex lenses, which helps the observer in reducing accommodation. This is a more diagrammatic representation. This is your subject's retina, which is illuminated. This illuminated image with the help of the convex condensing lens is created this image. This image comes, and this image is with the help of the prisms is diverted and converted this 15 millimeter distance into the this is like one side of the observer's eye, and similarly it is for the other side of the observer's eye. So here is like a binocular indication. So this is the illuminated retina condensing lens which creates the image, and this image is with this help of the prism systems is converted into interpupillary distance. Now here with these convex lenses, we can see this image more focused and more crisp image. So this is how your oculars are made up of. So basically this is the very key important point in the oculars. And this is exactly very simplified image. Here is the patient's retina, which is illuminated with the help of this condensing lens. Again, this aerial image of the retina is created. Now, we are not looking at here. We are going to look this. That's why it is known as an indirect ophthalmoscope. And this image comes to this with the help of these prisms. We are converting that image into the 65 mm IPD distance, and we can see this. So which type of the image is created? This image with the help of this high convex lens, condensing lens, 20 dioptric, which is more commonly used, is a real upside inverted and laterally inverted image. And this is how exactly I wanted to represent it in a more physics form, optical forms. So this is the subject's retina, and with the help of this proper illumination and the condensing lens, this image is created, which is like completely, it's inverted upside down as well as from left to right. Now, when we are using this, there are multiple aperture we come across. Like especially in initial part, when we set the certain things in the indirect ophthalmoscope, we have properly placed it, we have illuminated. Now, aperture size we have to choose. Now, there are the very small aperture, medium aperture, and the full aperture. Why we are having this aperture? Why can't we only go with the single aperture? To understand these things, there are certain principles which are very well explained by the Dr. Gulstrand, and these are known as the Gulstrand's principles. So, what exactly the first and main key principle of the Gulstrand says that in order to obtain the binocular view of the fundus and to make use of the available illumination, three images. Means one, the image of the illuminated retina, and then two binocular images that are created for the observer's right eye and the left eye. So all three images must be located inside the patient's pupil. Means at the patient's level, when patient's pupil has to be dilated enough to accommodate all these three images at the same time at patient's pupil level. So what exactly if that is exactly how it defines that if patient's pupil is not dilated, we are having very difficulty in having examination of the retina of the indirect ophthalmoscope. Now, in that case, if we are reducing the aperture size, how it helps? So first, it will reduce the size of this image. So these circles are becoming little smaller, and that can be accommodated in the smaller pupil. But does it only work at the patient's pupil size only? No. That is another thing as well. And this is exactly the second principle of the Gulstrand. What exactly this second principle says that? Second principle says that in order to avoid the bright corner reflection and the reflection from the surface of the crystalline lens, the distance between the light source image and those of the observer's pupil must be kept as much distance possible as much which patient's pupil permits. So this defines that we need some minimum pupil size to have all the three separate images which are spaced appropriately. And what is this minimum pupil size? That generally what in a documentation textbook is around 4 millimeter. If this pupil size is around 4 millimeter, that is adequate enough to examine the patient's retina with the help of the indirect ophthalmoscope with the smallest possible aperture. And this is exactly explains us the need of the multiple aperture of the indirect ophthalmoscope. So when we are having an adequate full dilated pupil, we can use the largest aperture. When the pupil size is mid-dilated or semi-dilated pupil, then we can use the middle aperture. And when not dilated and still we need to examine certain part of the retina, then we can try with the help of the smallest smallest aperture of the indirect ophthalmoscope. So now, after learning adequately about this machine and toy, how exactly we are going to place, one another important point is like a proper inclination of the oculus with respect to the examiner. Like once I have placed my headband, my oculus, how it should be placed. There is an inclination knob. So this is your inclination knob. This inclination knob is to arrange the proper angulation of this oculus. And how much this angulation should be? This angulation should be in a way that this oculus posterior surface should be perpendicular to the pupillary axis. And that is the proper placement of the indirect ophthalmoscope. Now, before we start to the procedure of when we are going to do with indirect ophthalmoscope, the first thing is we understood we are going to place now how should be your surroundings. So it is always desirable to have a semi-dark room or dark room. We generally switch off the room lights to maintain the proper low darker illumination. Then height of the couch should be proper. This is very silly point but very important point. And importance of this point we learned very well during our fellowship when when I still remember one of our retina head, Dr. Pramod Pende sir, he is a very tall guy. So to maintain that his height and this waist level, in addition to the using the proper table height, he used to add the wooden blocks to reach that table properly at his waist level. So that much is important. This will provide you proper ergonomics. In addition to the proper ergonomics, this is going to give you the proper alignment of the examiner's eye, condensing lens, and the peripheral retina in the same axis. So that is exactly how I'm going to describe in very simple way. Is if your table height is very well appropriately placed, then with this proper table height, we will able to achieve this alignment. The light source, condensing lens, and the peripheral retina very easily in a single axis. Now, when we will able to achieve this proper alignment, your need of the indentation will be relatively lesser or more lesser in aggression, lesser in this, and you will able to see the peripheral retina more easily. Your experience with for the patient is less painful or almost pain-free, and that is how this proper silly point, like arranging the proper height, is very, very important. Ideally, it should be exactly at the waist level of the examiner. If examiner is tall, it should be little higher. If examiner is little in a shorter in height, then again that has to be properly placed. So after this, the next point is obviously spine position is much easier. There are certain ways people are doing indirect of the retinal examination while in sitting posture, but that won't give you the adequate satisfactorily opportunity to examine the peripheral retina. So supine position is obviously the ideal and the most preferable. Neck, only certain condition where patient is on the wheelchair and where is may not be able to, and you only need to have close idea of the posterior polar surrounding up to equator pathology, then you may think about this sitting examination. Otherwise, this supine is strictly and purely required and indicated. Neck of the patient should be neither very much flexed. Patients are very helpful. Believe me, when you will lie down the patient and you are going to examine, they will try to move complete their chin up to make yourself more easy and make your patient comfortable and tell them not to flex much or not to extend much. Keep them slowly and just rotate their eyeball. That is exactly how it should be. So this crown is basically I meant for the indirect ophthalmoscope when when the early phase of the postgraduates, when they are learning a good skills, then once they will wear this indirect ophthalmoscope, the height of the headband that I exactly told you about the with the help of this knob. So this knob is going to help us in proper placement of the indirect ophthalmoscope in sense of the depth. How this depth is again guiding you in the placement. whenever you wear the indirect ophthalmoscope, this front edge of this indirect ophthalmoscope, lower edge of the front part of the indirect ophthalmoscope's band, that should be properly placed. How can I say that it's properly placed? Approximately one finger width above your uh, eyebrow. So that is exactly what is known as a properly placed indirect ophthalmoscope front band. So when the indirect ophthalmoscope is properly placed, so this is exactly what I wanted to show, that it should be properly placed, and this proper placement has to be done with upper knob. There is another knob. This is your second knob, and this knob will help you in guiding the circumferential fitting of the headband. Now you have placed it properly. Now you are choosing your aperture size depending of the patient's pupillary dilatation. And after that, there is a fine adjustment required, which is what I was talking about, the proper inclination of the oculus. So this inclination has to be properly in a way that your illumination axis is perpendicular to your pupillary axis. After this, we are going to adjust the pupillary distance, interpupillary distance, and this interpupillary distance adjustment is very, very important because if you have adjusted your pupillary distance properly, then and only then this indirect examination will give you the stereoscopic view. So exactly how generally we should adjust the pupillary distance is basically we illuminated the retina, or we illuminated the indirect ophthalmoscope, and this illumination node should allow you first close one eye, then illuminate your indirect ophthalmoscope, and now this illumination should be placed in a way that your prisms has an opening in front, and that opening will be exactly coaxial or exactly able to accommodate this illuminated beam completely. So here exactly what I was showing you with the help of the prism, that here when you are moving this knob, you are actually moving one of the prism, and that prism, with the help of this prism, you are making your indirect ophthalmoscope's IPD arrangement from the 15 millimeter of the diverted distance. You will do the same procedure with the other eye as well. One eye first, then same thing with the second eye. Now I'm doing with the second eye. After doing with the both eye, I will second eye, you open the both eye and see that your illuminated part is exactly in the center of your visual box. If you have achieved this, you have properly arranged your interpupillary distance, and now you are ready for the stereoscopic view with the help of the indirect ophthalmoscope. Now the third thing you are going to take is your condensing lens. And this condensing lens, there are multiple variety of the condensing lens. There are plus 14 dioptric condensing lens we have used. There is a pan retinal examination lens. There is a 28 dioptric examination lens. But more commonly and most widely popular lens is the 20 dioptric lens. And why it is very popular? If we understand how these lenses are works, then it will make our understanding more clear. Lower the power of this lens, like 13 and 14 dioptric lens we will see, then lesser the field and greater the magnification. Now, if I am taking the 28 dioptric lens, that will provide us larger the field, lesser the magnification. So 20 dioptric lens is the ideal combination of the both, with a reasonably good magnification and reasonably good field. Especially in the ROP babies, when due to the aggressive disease, the pupil is not dilating very well, and you are supposed to do the peripheral laser with the help of the semi-dilated or lesser dilated pupil. That is where exactly this 28 dioptric lens is very, very much useful. Now, which are the multiple designs of this lens? So this 20 dioptric lens can be plano-convex, it can be biconvex. Now, why we are not using the plano-convex? So basically, we are using the lenses which has a classical distribution of the 3:1. What exactly this 3:1 means? 3:1 means 3 times of the dioptric power is at the anterior surface, and one-fourth part of the dioptric power is adjusted in the posterior surface. So our 20 dioptric lens, this 3/4 part means 15 dioptric power is adjusted on the observer side, means anterior surface, while the 5 dioptric power is adjusted on the posterior surface. And this type of the asymmetrical biconvex lens we are using. Then why not the symmetrical biconvex? Why not the plano-convex? So to understand this, we will understand a few more things. When we are going to have a plano-convex lens with one surface as a 20 dioptric and second surface is a plano, this will have a much reflex-free view, but condition applied only if holded correctly, and that will only give you perpendicular vision, means that will give you very good vision of the posterior pole and little amount of the periphery, not so great in extreme periphery, but that will require significance. But if you will look at the biconvex with symmetrical lens, both sides 10-10, then this equal in either way. If ये lens, if you will hold anterior posterior anterior, मतलब in any way that will be equally, but that will have more amount of the reflexes or the lens induced refractions, artifacts basically. So that is the reason we use the biconvex lens, but they are the asymmetrically placed biconvex lens. Now, how to hold this? So whenever we hold, more curved surface should face towards you, and lesser curved surface should face towards the patient. But each and every time we cannot touch the lens and feel the surface, or we cannot like spend the time in like in a busy clinic, this is a more convex, so there is a silver line. And whenever you hold the lens, it should be like that, silver line should face towards the patient. Now, this is again one of the very important while developing this skill, how to hold your lens very properly. So first and foremost, I generally say that hold the lens in your non-dominant hand. Why this non-dominant hand? Like for example, if you are right-handed, use it in your left hand. Why in left hand? So that your right hand, which is your dominant hand, is relatively free, and you can use while indentation, so that the fine touching with the help of the indenter, you will able to achieve with the help of your dominant hand. Now, second thing, once you have holded the lens, how should you hold it properly? Then remember here, look at this image, how exactly we are holding. So your hand should be rested. To have a proper focus, your hand should be stable. And to provide this stability, your ring finger and the little finger will give you the support to have a proper stability of your hand. Then the middle finger you will use to retract the lower lid. Now, index finger and the thumb. In between the index finger and the thumb, you will hold the lens. Now, this arrangement will have an additional advantage of having a free movement of the hand, so that you can have fine focus with the help of the lens very properly. How this movement? Let me show you here. So can you see this? I'm moving, I'm trying to move the lens so that I can have this proper fine focal point, at which the entire, I'm having a mixed view of the retina, crisp clear view, along with the image fills my lens completely. Remember here, the filling of the entire view of the lens by the retinal image is very, very important. So this is, I wanted to show exactly what I said just now, that this image of the retina should fill your lens completely. Now here, if this is the another image where you can see this image is almost filling the lens, but not completely. Here at a crescentic artifact, and this crescentic artifact shows that still I am not at the right place. I am still away from the spot. So this is exactly how your retinal image should fill in your lens while you are having a view of the retina. Image magnification. So rather going into this complicated math, I will simply say that consider the reduced eye power of your eye or patient's eye. Like for example, your patient is -10 dioptric myopic. Now, general consensus says that the reduced eye power of the normal eye is a 60 dioptric. Now this patient has a -10 dioptric power. So now this patient's reduced eye constant is around 50 dioptric, and divide that power with the help of your lens. Like if I'm using a 20 dioptric lens, then in that case, so 50 dioptric power divided by 20 means I'm going to get the 2.5 times magnification. Now, if this patient might be the ametropic, then his reduced eye power is a 60 dioptric. Now my lens is 20 dioptric. So now I'm getting almost 20 divided by 60, 60 divided by 20 means a 3 times magnification. For example, my patient is having a -4 dioptric myopia, means his reduced eye constant is around 56 diopter, and I'm using 28 dioptric lens. So with that 28 dioptric lens, I'm going to get only 2 times magnification. So this is how the image magnification is there. And now with this lens, we used to say that image magnification and the field of view, image magnification and the field of view. With the standard 20 dioptric lens, with a monoocular view, we are going to get the 42-degree approximately illumination or 42-degree view. But when we are going to do the binocular examination, this view will reduce almost around the common area, that's a 40 dioptric illumination or a 50 dioptric field of view. So after this, we have wear the headband properly, we have holded the lens properly, we are having the center posture, we have started the retinal examination. Now, if you want to indent, first and foremost, scleral indentation is not mandatory in each and every case. Remember me, scleral indentation is not required for each and every case. So when it is required, when you cannot see the aura without scleral indentation, then and only then your scleral indentation is required. So after wearing this, and when you are going to start with the scleral indentation, before that you do examines, it is not like that from the beginning only you will start with the scleral indentation. First, try to examine your retina properly. If you are having the satisfactory view, at 360 degree you could see the view, then no need of indenting the sclera. But if you feel that no, in certain area you cannot see anteriorly adequately enough, in that case, with the help of the scleral indentation, you will bring that anterior part which was not in your view into your view with the help of the scleral indentation. Now, I will suggest that sometimes there are the cases where during retinal examination, you are able to see the periphery quite well. But this is a little more challenging when you are doing the laser, because to see some part is different, but to work on that part is again different. So when you are doing the retinal laser with the help of the indirect ophthalmoscope, that time you may need little more time the indentation than your regular retina examination. There are multiple types of the scleral indenters. So basically, with this help of the amount of the fluid also, because of the scleral indentation, movement of the fluid, we can confirm that there is a presence and amount of the fluid. And as I said, there are certain cases where there is a hemorrhage and we are not very sure whether it's a retinal break, round hemorrhage exactly, or retinal hole. So in those cases, again, the scleral indentation will help. So in a nutshell, scleral indentation will provide you the dynamic part of the dynamic part of the retinal examination or palpation of the retinal examination, in addition to the additional bringing the peripheral part in your view or in your field of view. So there are two. So even when you can see the periphery, but you are doing laser and you are still not very satisfied, or you have some confusion with the fluid, so those are again the time when scleral indentation is required. And with the scleral indentation, as I used to say that while doing this, your fine movement of the hand should be so thorough and so easy that you will able to bring your scleral indentation, your lens or field of the retina with the help of the scleral indentation, your lens and your illumination, everything in a same axis. There are multiple type of the scleral indenters available, but most commonly indenter which we use is this thimble indenter, and this pen type indenter is again which is known as a socket indenter. These are the commonly used indenters. For the pediatric or ROP patients, we use this paid pediatric skin indenter, or sometimes we may use the Vectis.
I'm very sorry to interrupt, sir, but in the
Yeah.
interest of time, can we wrap this up quickly?
Yeah, I'm almost about to finish, only few last slides. So now how to indent?
Yes,
When we are going to indent, first move the patient in the opposite side, put the indenter, move the patient towards the indenter, so that with the help of the passive movement of the eyeball, that should be indent. You should not indent actively and pressing the eyeball. You should only use the eye movement. So that is exactly how we are going to use the indenters. And so basically, while indenting, if your patient is facing too much pain, that can be your excessive pressure, or not placed properly, or patient IOP can be higher, or uh, avoid the indentation over the limbus, over the tarsal plate. If patient has recent intraocular surgery or penetrating trauma, avoid the indentation. And with the help of the certain tips and tricks, initially you may face the problems while dealing with the indirect ophthalmoscope, which you will slowly learn while doing more and more. So indirect ophthalmoscope is more about the practice, practice, and practice, rather than proper like one-time schooling or one-time teaching. More the practice, you will learn it more. And if we will look at the history, the indent, first time pioneer, this indirect ophthalmoscope is made by Dr. Alvar Gullstrand, and that is how this Gullstrand principle 1 and 2. And this first indirect ophthalmoscope was created in 1910. Thank you.
Thank you so much, sir. I think that was very beautiful presentation and a lot of nuances to indirect ophthalmoscopy, which were very beautifully simplified. Timeless skill, which is not just limited to retina specialists, but I think each and every ophthalmologist should be very familiar with indirect ophthalmoscopy. With this, I would like to invite Dr. Apurva ma'am to give her comments.
That was a really good presentation, Dr. Pradeep. Thank you. Like you said, it is not a one class, it is more of a lifelong learning, I should say. One practical tip that I would like to give all residents is that they should aim to do at least one or two indirect ophthalmoscopy every time they are in OPD. And in retina postings, when they come for either 3 or 4 weeks, it's better they make 2 to 3 drawings every single day. It could be of any case, and that's how we learn. And about positioning, you made some very good points about how the distance should be. Like if people of different heights, for example, short people cannot, achieve that distance between the patient's eye and their eye. So it's useful for short people to, have a small stool or something. And tall people have to tilt their bodies extra, especially for ROP screening and everything. So these are some practical problems which comes in extremes of heights of observers. And indentation, the first time we start to learn indentation, we can always try on myopic eyes because they have thin scleras, they're easily indentable. Also, myopes, we can directly see the aura. So, if a new resident wants to see the ora serrata, myope of -4, -5 onwards is an ideal candidate where they can see the aura directly. Other than that, it's like, you do 500, 600 IDOs and then you start getting the hang of it, and then you learn to tilt your head, learn to tilt the light, and you learn to position the patient's head to get the best possible view. It's there is a learning curve, but the view of the retina at the end, when you have the satisfaction of locating that break or indenting a small hemorrhage and making sure it's not a break, these are the moments where you feel okay, now you feel confident about indirect.
Thank you, ma'am.
Thank you.
Dr. Mona, ma'am, just a quick comment from you.
Yeah, thank you, Pratik, for a very nice to see you
Thank you, ma'am. Even I'm also glad to present it
from the
in front
first
of
class
you.
you did with us. Yeah, I
Yeah.
think a lot of practical learnings, and I think indirect ophthalmoscopy is not a skill only for the retina specialist. For us, it is something that is part of our routine. But even for a cataract surgeon, especially if you have a PC rent during surgery, doing an indirect ophthalmoscope on the table will help you understand whether there is a cortical matter or nucleus piece which has gone down, which needs to be taken care of. I probably say that is my single important message of this class.
Thank you, ma'am.
Thank you so much, ma'am. One small request to all the speakers is to restrict their time of presentation to 30 minutes, as we'll be having discussion afterwards as well. So with this, I would like to invite
I'd like to make one small comment.
yeah, please, ma'am.
See, the thing is that he covered it very beautifully, Pratik. You dealt with all small
Thank you,
nuances.
ma'am.
But just one kind of tip. You didn't mention that when you position the light, you always have to see that it is on the upper part of your hand. If you keep your hand at 1 foot distance, the light, when you adjust it, it has to be in the upper part of the hand. So then when you look into the eye, it gives you the whole view very clearly. Second thing is that one very important thing which I tell my residents is that when you are doing indirect ophthalmoscopy, you have to do it royally. You have to be, it's like a king's posture. It is not a hunched bent posture. You have to be straight. You have to be back, and there is a slight tilt of the side and a slight
Yes,
tilt
yes.
of your head, which will give you that exact alignment, which will give you a beautiful kind of full picture on the lens. That's all I had to say. But otherwise, good presentation.
Thank you, ma'am. Thank you.
Thank you so much, ma'am. Very nicely put. So we would move on to our next presentation, which would be clinical fundus examination. As people say, visualizing the retina is like a looking into the window of the body, where we can actually see the nerves and the vessels. So I would like to invite Dr. Sonam Verma, who will be talking about clinical fundus examination. And can you please share your slides?
If you're facing any difficulty, ma'am, please let us know. We'll help you.
Ma'am, can you hear us?
Samir, you can go to the next presentation if that's okay. Maybe there are some.
Okay,
She's.
okay.
Yeah.
Okay, so in the meanwhile, we would like to invite our next speaker, Dr. Shweta Walia, who will be talking about fundus fluorescein angiography. Probably when the retina whispers, FFA is the thing which makes it speak. Over to you, ma'am.
Thank you, doctor. So is my screen visible?
Yes, ma'am.
So good morning, everyone. So today's topic for my deliberation is fundus fluorescein angiography. As rightly said, so why does retinal vascular imaging matters? Because understanding the retinal disease begins with understanding the retinal blood flow. Different retinal disease have different triggers, but vascular dysfunction is the final common pathway. So what the various vascular events that usually occur? There is a vascular wall damage and breakdown of blood retinal barrier leading to capillary leakage And finally, because of vascular damage, there might be capillary non-perfusion, leading to ischemia and VEGF upgradation, and finally the neovascularization. So regardless of etiology, most retinal diseases converge onto a few vascular endpoints, and imaging helps us to identify exactly where the disease is active. So vascular dysfunction is the earliest and most decisive event, and structural changes occur after the vascular compromise. And accurate visualization of retinal circulation helps us to make early diagnosis, disease staging, treatment planning, and monitoring the therapeutic response. So we can do imaging, either the invasive one, that is the FFA, fundus fluorescein angiography, or for the choroid we can use the ICG, indocyanine green angiography. The non-invasive means to assess the retina are the OCT, and to see the vasculature, OCTA angiography. So when we compare the fundus fluorescein angiography with OCT and OCTA, we see that we can see leakage only on FFA. Perfusion can be seen on FFA and OCTA. The structure are best seen on OCT. But to see the peripheral retina, or to capture the vascular changes occurring in the peripheral retina, only FFA comes to our help. And advantage of OCT and OCTA is that they are non-invasive, but to say FFA is still the gold standard for retinal vascular study. So let's see what are the various anatomical consideration. We know that the retina gets its blood supply from the central retinal artery and the short posterior ciliary arteries, and the inner blood retinal barrier is formed by the vascular endothelium, and outer blood retinal barrier is formed by the RPE cells, and capillaries have a non-fenestrated endothelium. So fundus fluorescein angiography essentially assesses the health of both inner and outer blood retinal barrier. So over here you can see that the outer blood retinal barrier is formed by the RPE, and RPE presents an optical barrier to the fluorescein and masks the choroidal circulation. So whenever there is RPE atrophy or damage in the RPE, we can see the underlying choroidal fluorescence. And the inner blood retinal barrier is formed by the endothelial cells, which prevent the leakage of fluorescein and the albumin bound fluorescein, and so we can see the picture of retinal blood vessels. But whenever the blood vessel walls are damaged or compromised, there is leakage of fluorescein from the vessel wall, which can be seen during angiography. So let's see what is happening when we are giving dye to the patient. So when white light goes, the blue filter allows the blue light to enter, and it stimulates the fluorescein molecule, which jumps to the higher orbital level, and when jumps back into a lower level, it emits the green wavelength. So green filter allows only the green light to come out, and which stimulates the photographic film, and we can see the fluorescence. So sodium fluorescein is a xanthine derivative. Its molecular weight is 376.27 Dalton, and we usually use a dose of 3 ml of 20% fluorescein. Maximum adult dose that can be given is 1000 milligram according to the 15 milligram per kg body weight, and pediatric dose is usually half of the adult dose, 7.7 milligram per kg body weight. So those having poor intravenous access or in the pediatric population, we can still use oral fluorescein. And how can we prepare this oral fluorescein? Capsule I have not seen available anywhere, but we can use the 10% liquid fluorescein sodium and mix it with juice to mask the unpleasant taste. And according to the dose of 25 milligram per kg body weight, we can give it. A normal angiogram, when we use an IV dye, we can see the retinal vessels at 12 seconds. But when we are using oral fluorescein, the good quality angiograms can be taken 30 to 60 minutes following the ingestion. The complication or the side effects are less common with oral fluorescein than the intravenous administration. So we know that the fluorescein dye has ability to fluoresce in visible spectrum. The peak absorption is at 485 nanometers, that is the blue wavelength, and peak emission is at 530 nanometers, that is the green one. It has high solubility and stability. binding to plasma protein is 7 to 80%, and it is excreted through renal system. And that's why after fluorescein angiography, we tell the patient that they will have an orange urine, and that is because of the dye. The limitation of sodium fluorescein is that it doesn't permit the study of choroidal vasculature, because melanin, the RP, absorbs all visible wavelength in the visible spectrum, and there is poor protein binding which makes it leak through the capillaries. And it also doesn't possible to study when if the patient has high hemoglobin concentration or high serum proteins. And there are many times, sometimes we have adverse events also. The absolute contraindications to FFA is allergy to iodine compounds or a past history of severe adverse effect following dye ingestion. And relative contraindications are asthma, allergy, cardiac failure, MI, renal failure, hepatic failure, or GTCS. And in pregnancy also we try to avoid FFA. Now coming to the understanding of the machine, this is the Fundus fluorescein angiogram machines, the Fundus camera. It's a low power microscope, and once you have focused the retina with a mechanical joystick, you have to fine tune the fine focus it with a fine optical focusing system. So indications of FFA is to establish and confirm eye diagnosis, to aid the treatment decision, and to assess the response to the treatment. So before doing the FFA, you must do your settings properly. So you wear your distance glasses and take a piece of cardboard in front of the objective lens, and you can see a reticle over there. So set the eyepiece to maximum plus diopter, and you will slowly move it forward and so as to focus the reticle. Once the reticle is focused, you will keep that as the eyepiece focus, and this helps to get a clear image. So once you are capturing the photograph, you have to ensure both the retina and the reticle are completely clear, and this can be done with the fine focusing device. So you have to take a complete informed consent from the patient, because many times we may have some adverse events. Dilate the patient pupil, take a baseline arterial blood pressure, it should be normal. Put an intracath on the patient, avoid using butterfly intracath, and prepare the fluorescein solution, prepare the fundus camera, keep your emergency drugs ready, and physician should be readily available. First, you'll take the fundus photographs, followed by red-free photographs, and then inject the fluorescein dye. So what are the emergency drugs you must keep prepared as injection Evil, injection hydrocortisone, ondansetron, adrenaline. You must also be prepared with nebulizer, oxygen cylinder, ambu bag, BP apparatus, pulse oximeter, IV cannula and fluids, and suction apparatus. So this emergency kit must be there in your FFA room. So what is your angiography plan? You have to, after injecting dye, you have to click photographs very fast, because it takes only 10 to 12 seconds to reach to the retinal, and you don't want to miss the early phases of the photographs. So once you inject the dye, you have to press the blue filter, then the green, and then the timer. So as you in this sequence, as you press it, there is completely blackout, and you are not able to see the retina till dye comes into the retina. So you have to be very quick and accurate in your focusing, so that you can capture the early phases. So for 1 minute, you have to click it very fast. After 1 minute, you take photographs of area of interest, and then late photographs can be taken at 3, 5, and 10 minutes. So what is the normal plan for angiography? You take baseline fundus photographs, and then the red-free photographs, and then you capture the 5 phases of angiograms, that is the choroidal phase, arterial phase, capillary or the arteriovenous phase, recirculation, and the late phase. So arm to retina time is 7 to 12 seconds. Posterior ciliary artery fills at 9 seconds. Choroidal flush and the cilioretinal artery can be seen at 10 seconds. Retinal arterial phase starts at 10 to 12 seconds. Over here, you can see that the retinal arteries have started to fill, and the veins are still empty. The capillary transition phase starts at 13 seconds. Early venous or the lamellar phase is at 14 to 15 seconds. Over here, you can see that there is lamellar flow in the veins. So this is the early venous phase. Then comes the venous phase at 20 seconds when the fluorescence in the arteries and the vein is equal, and it is the best time when you can comment upon the foveal avascular zone. This is at the 20 seconds. Late venous phase starts at 30 seconds when the dye in the arteries has starting to reduce, and in veins it is at full phase. Late phase, when the dye in the arteries and veins has reduced and you can see the disc staining, which is at 5 to 15 minutes. So what are the various abnormal fluorescence you can see? It can be either hyperfluorescence or a hypofluorescence. So what are the causes of hyperfluorescence? It can be either a pseudofluorescence, autofluorescence, window defect, leakage, pooling, or staining. So what is pseudofluorescence? It is because of the mismatch of the filters. So crossover in the spectral transmission curves of exciter and barrier filters causes pseudofluorescence. The structures which do not fluoresce are also seen as hyperfluorescent. So if before injection of dye and the normal structure are also appearing fluorescent, then it indicates that you need to check your filters and then take the photographs. Autofluorescence is few structures are highly refractile in the same spectral range as the fluorescein dye, and this is usually the optic nerve head drusen and atrocytic hematomas. Now, we discussed earlier that RPE, where melanin is highly pigmented, you can't see the choroidal fluorescence. But depending upon the density of the retinal pigmentation, the background fluorescence of choroid can be visible as hyperfluorescence. When there is loss of the pigment, it allows visualization of the fluorescein created by the underlying choriocapillaries. And what is the characteristic is that the size remains uniform throughout and brightness rises initially and then falls with the choroidal fluorescence. So where here you can see that the size is remaining static throughout the angiogram and fluorescence decreases. Now coming to leakage. So leakage is extravasation of the fluorescein dye from the disrupted retinal vascular endothelial cell tight junctions or breakdown of the tight junction between the retinal pigment epithelial cells. So in the first photograph, you can see there are multiple hyperfluorescent dots along the blood vessels, and in late phase, these hyperfluorescent dots have become fuzz. That means that there is leakage from these dots. So when you correlate these angiograms with your fundus photo, the hyperfluorescent dot can be seen as red dots along the blood vessels, that is the microaneurysms, and in late phase, these microaneurysms has leak, indicating a focal leak. So coming to pooling is accumulation of dye within a distinct anatomical space. So the size and intensity both will increase in initial phases, and then it will the intensity will decrease once the cavity is completely filled. So you can see in the fundus photograph, the blister of CSCR is there. In initial phase, there is a point leak, which gradually increases in size and intensity, and it will completely fill the blister in the late phase. So in this, you can see a characteristic smokestack appearance of CSCR. Now coming to staining, it is late hyperfluorescence due to accumulation of fluorescein dye, and characteristically in the late phase, you can see optic disc staining, and drusen also takes stain in the late phase. Now coming to hypofluorescence, it can be because of either a block fluorescence or a filling defect. Now block fluorescence indicates it is because of the blockage of fluorescein. It can be either because of blood or it can be because of pigmentation. Now hemorrhages can be either a pre-retinal hemorrhage, intraretinal, a superficial or a deep, or a subretinal or a choroidal hemorrhage. So over here you can see in the fundus photograph, you can see a boat-shaped hemorrhage, and the underneath retinal vessels are not seen. And if you see the angiograph photograph, there is characteristic boat-shaped hypofluorescent area which is corresponding to the hemorrhage, and there is blocked both retinal and the choroidal fluorescence cannot be seen underneath it. So it is a pre-retinal hemorrhage. Now over here you can see that there is a hyperfluorescence, block fluorescence is characteristically flame shaped, and it corresponds to the flame hemorrhage of the fundus photo. And associated hyperfluorescence spot of the cotton wool spot can also be seen, and underlying choroidal vessels are not seen, indicating a superficial hemorrhage. Now these are dot and blot hemorrhages, hyperfluorescence because of block fluorescence because of dot and blot hemorrhages. Now over here you can see that the retinal vessel can be seen over the block fluorescence area. So it indicates a subretinal or a choroidal hemorrhage. Now block fluorescence can be either because of filling defects. Over here you can see this well marked area of block fluorescence which is marked by the retinal vasculature. So this is indicating a filling defect, and because of lack of retinal perfusion, this is a capillary dropout area, and it indicates ischemia of the retina. Over here you can see that the choroidal circulation is not being seen, only few of the blood vessels are filling and the remaining are there is no fluorescence in the blood vessels. So how do you do a reporting for fundus fluorescein angiogram? You have to indicate the arm to retina time. Normally it is 12 seconds. If it is more than 12 seconds, indicates problem with the fluorescein dye injection, or there is some circulatory problem with the patient including heart or peripheral vascular disease. You have to mention the AV transit time, whether it was normal or it is delayed. If it is more than 20 seconds, it indicates a delayed arteriovenous transit time, which is characteristic of CRVO and CRAO. You have to comment upon the foveal avascular zone. It is best studied at peak phase, as told earlier, when the fluorescence in the arteries and the vein is equal, and you have to comment upon its contour, whether it's irregular erosion of parafoveal capillaries, whether there is widening of the intercapillary spaces, whether there is any intrusion of the dilated capillary beds, or presence of any arterial stumps at the FAZ margins. Then you have to comment upon the abnormal fluorescent areas and their course in the late phase, whether there was hyperfluorescence, whether that fluorescence has increased with the passage of phases of FFA, or whether it has increased in size or has remained same. In late phases, you have to indicate whether leakage has increased or there is staining, especially of the optic disc. So the Guru mantra is that leakage grows, staining glows, and pulling fills, and blockage hides. So this is the Guru mantra. So to know whether it is a hyperfluorescence, what is the cause for hyperfluorescence and what is the cause for hypofluorescence. So let's take few example. How do we do the reporting of an angiogram? So over here we just have one photograph. So over here you can see that there is lamellar flow in the vessel, early venous phase is there, and you can see multiple hyperfluorescent spots. And if you had a fundus photograph, these might have correlated with the small red dots along the blood vessels. And if you had the later phases, you have to see whether these hyperfluorescent spots have leaked in the late phase or not. If they are leaked, it indicates that there is a focal leakage from the microaneurysms. You have to comment on any blocked hypofluorescent areas. Over here you can see that there are blocked fluorescent areas which are marked by the blood vessels indicating capillary dropout areas, and you have to comment on the FAZ. So FAZ is irregular in this with the intrusion of the blood vessels into it. So all these things must be covered when you are explaining your angiogram. So now this is another question for you all. You can see over here that this is an arterial phase. The veins have not started to fill, only the arteries are filling. There is patchy choroidal filling, and over here you can see that there is the leading edge of the dye. So it indicates an ocular ischemic syndrome. So now this is another photograph. Over here you can see that the arteries are full with the fluorescence, and in veins there is lamellar flow. So this is early venous phase. Or the disc is hyperfluorescent. There are multiple areas of blocked fluorescence in all the layers. Over here you can see the superficial flame shaped blocked fluorescent areas. Over here you can see the dot and blot hemorrhages. So hemorrhages in all the four quadrants with hyperfluorescent disc There is not filling of the veins in the superior quadrants, delayed filling of the arteriovenous phase. So it indicates a CRVO. Over here, you can see that the vessels are not filling, and these vessels are over the veins. So these are the arteries. There is not filling of the arteries. So this is branch retinal artery occlusion. Now, how to comment upon the FAZ? This is the normal FAZ. Over here, you can see in the second picture, you can see that the FAZ is increased in the size. There is intrusion of the blood vessels into the FAZ areas. And also, you can see that there are multiple hypofluorescent spots in the periphery with a hyperfluorescent margin, indicating that this patient had undergone an laser therapy earlier, might be for a proliferative disease. So after reading your angiograms and everything, still many of you might be thinking, when we can do with a non-invasive technique, what is the need of an angiogram? So let's see what are the advantages of FFA over OCT. So in FFA, you can clearly know whether it's an ischemic or a cystoid maculopathy. You can differentiate pseudophakic macular edema from diabetic macular edema. In the first picture, you can see there is a characteristic petalloid appearance, while in the second, you can see that there are multiple, there is focal and diffuse leak. This is diabetic macular edema, and this is pseudophakic macular edema. So this you can only differentiate on a fluorescein angiography. To differentiate intraretinal microvascular abnormalities and neovascularization elsewhere, edemas can be seen as vessels between two major vessels. These may or may not leak, but neovascularization always leaks. To detect the FAZ, though OCTA also gives us helps us to know the FAZ abnormalities, but OCT alone will not help us to know what is the status of FAZ. To determine whether macular edema is due to focal or diffuse leak. So over here you can see that there is focal leak, and over here you can see that there is diffuse leak. To identify the treatable lesions when we are treating the CSME, whether you will go for focal laser or a grid laser, to identify persistence, progression or resolution of macular edema, neovascularization elsewhere, neovascularization disc following laser photocoagulation. Now, retinal vasculitis is something where FFA only helps us. It is gold standard for diagnosing and monitoring the retinal vasculitis. You can know the perivascular dye leakage, areas of capillary non-perfusion even in the periphery. OCT detects complication of vasculitis like the cystoid macular edema or the serous detachment, but it will not tell what is the status of the vessels which is leaking. OCT, it provides a non-invasive perfusion maps, but still it cannot demonstrate areas of active leakage. It cannot take the pictures of peripheral retina. So OCTA complements, but it cannot replace FFA. So there are a few pitfalls of angiography. We cannot, though indirectly we can know that macular edema is due to traction on fundus photo or angiography, but ideally, for if you need to know whether it is because of traction, OCT is going to help us. FFA is not able to image the choroidal circulation, and for choroidal vasculature, we need to do an ICG. If there is an occult CNVM or a retinal angiomatous proliferation, PCV, CSCR, choroidal hypermobility, and better vessel dissection for the feeder vessel and its treatment by laser. So OCTA is definitely a great help, but still FFA is better when you are detecting low flow characteristic lesions like the microaneurysms or some polypoidal lesions. And FFA and ICG has ability to capture much wider area of retina and choroidal circulation, and also FFA is easier to interpret than OCTA. To conclude, FFA remains a gold standard for evaluating the retinal vascular pathology. OCT just shows the structure, OCTA shows flow, but only FFA shows leakage and perfusion dynamically. Not every patient's FFA, but some diagnoses cannot be made without it. FFA is indispensable in retinal vasculitis, ischemic diabetic retinopathy, and retinal vein occlusions, unclear CNVM, peripheral retinal ischemia. Always interpret FFA in clinical context and with OCT and OCTA correlation. Patient safety is paramount. know the indications, contraindications, and the emergency drugs. Thank you.
Thank you so much, Dr. Shweta Walia, ma'am, for that clear and comprehensive presentation on fundus fluorescein angiography. You've explained the patterns of FFA in a very systematic manner, making this complex topic very easy to interpret in routine practice. Before we go ahead, I have a small question. In our day-to-day practice, what are some of the common mistakes while interpreting FFA that can lead to errors on the side of postgraduates or early beginners?
So most of them, they usually don't take the early photographs. And many times that are missed, and they don't correlate with the fundus photos and the late pictures. You can't comment FFA on just one photograph. You have to take the sequential photographs, and you can't rely on your optometrist that he has done everything. You have to be there when you are doing the fundus fluorescein angiography. So in my practice for so many years, I still, for any patient, if I have any doubt, I myself go and do everything. I don't let my anyone else take my pictures. I take my pictures of the area needed by myself.
Thank you, ma'am. At this juncture, I'd like to invite our esteemed panelists to share their insights, tips, and some personal approaches to interpreting FFA in certain challenging scenarios. Dr. Karobi, ma'am.
Hi, Shweta, very nice presentation. You presented everything in a very systematic manner. Only one of few additions which I'd like to make is that when you talk about oral fluorescein angiography, sometimes people make the mistake of giving it in milk because the child has milk and all, but don't ever use milk because the gastric emptying time is delayed, and the fluorescein angiography pictures are very unpredictable and they don't come out well. So it's always juice or glucose water, which is generally used for the oral fluorescein angiograms. And another thing which I wanted to highlight is that you spoke about all the emergency medications, and as you said, that the early pictures are the ones which kind of get neglected if you don't really start photographing the pictures. I mean, take the pictures right in the early part. So that has to be highlighted. In your last slide, only one more indication you should add is CSR, because we have to know that where is the early leak, and that is the area which has to be highlighted. And I think that's about it.
Thank you, ma'am. Thank you.
Yeah, can I?
Dr. Muna,
Yeah,
yes, ma'am, please go.
excellent talk, Dr. Shweta. I wanted to add that with our newer cameras, especially the wide field cameras, you get excellent oral fluorescein images. So previously we used to say you can only go look at it for pseudophakic CME, where you get the 30-minute phase, but you can get very excellent photographic images with oral fluorescein, especially in the wide angle view, which we use for children if we are looking at peripherally vascular retina and things like that. So I think that is something we need to know.
Thank you, ma'am.
Thank you, ma'am. Dr.
Yeah.
Apurva, ma'am, would you like to add your...
Thank you, Shweta ma'am, for that very nice presentation covering many nuances. I just want to encourage all the residents and fellows to know indications of FFA. With the advent of OCT angio, there is a higher threshold to do invasive angiography nowadays. So, but there are, like you use the word, FFA is indispensable in certain indications. Some of my indications would be like whenever a VKH or an APMPP mimics CSC, because both of them have neurosensory detachments. FFA can be very, very useful in at least demonstrating to people who are not convinced that it is choroiditis and not CSC. So CSC will have your ink blot leaks or a smokestack leaks, but choroiditis in terms of say APMPP or VKH especially will have early pinpoint, that starry sky and late pooling. And vasculitis, like you mentioned, if you want to distinguish between a hypertension causing a CRVO or a vasculitis causing a retinal vein occlusion. FFA is very, very telling of whether it is vasculitic occlusion or something related to hypertension. In diabetic retinopathy, yes, especially when you want to add a laser, focal laser, yeah, like you said, focal leakage can be very valuable. And I don't know if you mentioned asteroid hylosis is a very important indication for FFA if you want to see whether there is PDR. And just one more point about FAZ is that it has to be commented on in the early AV phase before the microaneurysm start leaking and obscure the foveal avascular zone. That's just what I wanted to say.
Thank you, ma'am. Dr. Prashant sir, would you like to add?
Yeah, beyond the retina and macula posterior pole, we also need to understand fluorescein angiography, especially for the disc in neuritis and all. Picking up whether it's a leaking disc or a hot disc or not, it is very important. That thing we can definitely be looking for, especially when Purva said when it is a case of a VKH, you will have a hot disc which is leaking as well. Now, with the advent of wide field fluorescein angiography, newer indications have cropped up for this. Especially, you can see the peripherally vascular abnormalities in beta codes or any telangiectatic vessels, or you can pick up a very nice von Hippel-Lindau angiomatosis and all can be more picked up. So these are the extended indications which we could not, which an OCTA cannot pick up. So if people say that it is phasing out, I don't think so. It is phasing out with a wide field. In fact, the indications are getting expanded rather.
I just remembered another small point which I'd like to make is that when you are doing the angiogram, the instructions to the patient have to be explicit. You have to tell him that he might have a sensation of vomiting, and if he feels that, he has to open his mouth wide and take deep, wide breaths without taking his chin off the from the slit lamp. Because the thing is that otherwise you miss out on the phases if the patient moves, and I mean, you don't get the pictures and you start getting it from the AV phase when his feeling has passed off. So these instructions are very clear, have to be clear to the patient, and it helps your angiogram to a major degree.
Just one small question to all the panelists. Like, we talk about the adverse effects of fluorescein, intravenous fluorescein, and we also know that there is a theoretical risk of even mortality, like 1 in 2 lakhs or something like that. So practically, like in our day-to-day practice, although we have that emergency cart in our, what sort of adverse effects and how often do we see that with the intravenous fluorescein?
Munna ma'am or Karubi ma'am. More
Yeah, touch wood not. We've had recently, I remember one patient who had anaphylaxis, but luckily we have our code blues and we have our crash cuts in the FFA room. So, I mean, she did recover. So I think it's important to make sure your crash carts are fully equipped. And sometimes we even give, if we think there's likely to be a problem, then a steroid injection and antihistaminic is given even before the procedure. We don't do the skin test. I know many people do it because we know that extravasation itself can cause necrosis. So I know a lot of places they do the skin test, but we don't do it. But if we think there's likely to be a problem, then we give the steroid and antihistaminic before starting the procedure. And I think I unfortunately no longer have the luxury of being able to go and do my own FFAs. But I think it's more important when you're in a big institute where there is one place and you have 10 of us sending cases, to be very clear about which eye you want first, which quadrant you want first. Because unlike OCTA, you cannot go back and repeat an FFA if you miss something. So I think if we can't just say FFA both eyes, you need to say this is the area I'm interested in. This is what I want early pictures of. I always do the other eye, especially if you're looking at filling. And if you don't see the dye and otherwise you think the patient is okay, just lift the arm and the dye will flow into the circulation. Yeah.
I know in all these years, I think we've hardly had one or two patients who had some kind of anaphylactic issues where we've needed to give some injections, but nothing really major. One thing which they generally sort of come up with is a lot of people have the sensation of itching after you've given the injection. So you have to again give them the requisite medications to allay that. And one other small tip which we generally do is that maybe you can just inject a little bit of dye in the beginning, but take a few pictures also because you shouldn't miss out on the early phases. And if the patient is okay with that, then go ahead with the rest of it within a few seconds.
At our center, we follow certain protocols. For example, a patient who is a known asthmatic, allergic to multiple drugs, or a patient who is quite morbid in the form that he is having multiple systemic problems like cardiac and all, we do it only in the presence of an anesthetist. Rest all are done by our technicians who do it, but they, as very rightly said by Dr. Muna ma'am, the crash cart and everything should be ready, and your technician should in himself be able to push the F-choline and the first antihistaminic. That is the thing. So they are warned there is nothing wrong, even if there is a slight uncomfortable sensation in pushing an F-choline, and that can be a life-saving or a golden moment. So they should be very clearly instructed. All your technicians should be knowing it. The moment the patient complains anything abnormal, you inject F-choline, and that can be quite a game-changing thing, rather, or a life-saving change. So any morbid patients, asthmatic and a very highly allergic patients, always do it in the presence of anesthetist. Second thing is, never we usually use a scalpel set for pushing the dye. At our center, we use only intracaths to push the dye. So, because if there is an anaphylaxis, there is a collapse of all the peripheral vasculature. And then, even if you have to push a large amount of drugs or the fluids, you can never get a vein. So the thing is, always go with an intracath. It is always worth investing into intracath, because intracaths are costly compared to a scalpel set. But never do that mistake. Always use an intracath whenever you are doing a fluorescein angiography.
Thank you so. Thank you so much to all our panelists for their very valuable, very real life-saving practical points. And now, without further delay, I'd like to welcome Dr. Sonam Verma to please start her talk on clinical fundus examination. Over to you, ma'am.
Thank you. Am I audible at the moment?
Ma'am, can you just make
Yes,
it in the
ma'am.
slideshow mode, ma'am? It's audible and visible.
Yes, ma'am.
Hello.
Yes, ma'am. You're perfectly audible. Just go to the
Yeah.
slideshow mode. Yeah, perfect.
So before I commence, I would like to apologize first for the glitch earlier. And with that, I really want to thank the opportunity to present at GuruSangam this year. So clinical fundus examination. It's one of the most difficult but yet enjoyable once you have the experience of learning and growing in the examination techniques. The specific learning objectives of the presentation and an experience sharing is to review clinically relevant fundus anatomy for systematic approach alongside understanding the ophthalmoscopy techniques for improving real-time fundus examination. But before we begin, the ultimate essentials need to be followed. For binocular kind of ophthalmoscopy, it is essential to know the interpupillary distance scopic image before meet and greet. That is where the patient has to be in front of you, and that time you cannot start away with the procedure itself right away. It's good to introduce oneself and also check the identity of the patient before commencing. Gain consent after explaining the procedure. It may be verbal as well. Ask if the patient if has any pain, allergy before proceeding. Examine anterior chamber for signs of any recent surgery, open globe injury, and depth of anterior chamber, where you have to do any physical maneuvering for the in contact with the globe. What's the need of ophthalmoscopy or fundoscopy? The terms related to clinical fundus examination. First, to detect pathologies of vitreous, retina, optic nerve, and vascular origin. Plan further investigation if needed to delineate our probable and final diagnosis. It also reveals related systemic manifestations and need for referrals or urgent referrals. And last but not the least, when we have to do laser delivery through indirect ophthalmoscopy, this technique needs to be mastered. The fundus examination instruments include direct ophthalmoscope, second, by the slit lamp biomicroscopy with contact or non-contact lenses, and finally, indirect ophthalmoscopy with condensing lenses. We can start using the direct ophthalmoscope as COVID has gone, but it has become a convenience to go with the other examination techniques. At the moment, if a patient is having any kind of communicable disease, that time we may use mask or refrain from it, but it really needs to come forth in our institutes. So in any kind of ophthalmoscopy, we need to follow the algorithm of positioning the patient comfortably according to the requirements of the mode we are choosing. Check for opacities through distant direct ophthalmoscopy if you're doing a DO. Then first of all, try to examine the optic disc followed by blood vessel, then the macula, and finally the retinal peripheries, completing the examination. The components which are causing this problem is that the patient's head and eye are unsteady. We are not acquainted to keeping our condensing lenses in place when we are using. Positioning the ophthalmoscope or slit lamp or our head and eye in alignment with the view we are having. So one by one, steadily we can go with the stabilization of all these modifiable factors. So here I share a nice sketch where on the left it is the side facing you in a direct ophthalmoscope with the brow rest where you place your brow, the viewing port through which you have to align your eye for a good view, the lens indicator which shows which lens you are using by using the lens wheel or also known as Ricos wheel. And towards the patient, we have a filter selection. We can identify these two horizontal wheels on the patient side and place the ophthalmoscope rightly. So the filter selection includes the red free, sometimes cobalt filter. Also, there might be a grid which helps in localizing and the lesions or checking eccentric or centric fixations. The aperture selection according to the size of the pupil and slit is also available. The power switch, or we call it the rheostat, from where we can turn the ophthalmoscope on and off, also control the brightness. Finally, the battery handle, which helps in a good grip, and also it holds a battery inside which should be placed and removed while we are using for good longevity of the device. Now, the optics, I won't go much into the detail for the paucity of time and doesn't align with my objectives where I want to give clinical bits about the whole presentation. So first of all, the image is erect and magnified. Although we have a small field of approximately 5 degrees, but it gives a very good high magnification of 15 times. So how to hold a DO? Over here, we can see how the fingers curl on the handle. The thumb should be placed in a way so that you can control the on-off switch drum here, and the index finger should be on the Ricos wheel. It should be finely placed and your brow should be resting on the brow rest towards your side. Start with the distant direct ophthalmoscopy, keeping the patient steady. At this point, you can ask the patient to rest their head on the headrest of the seat. Slowly approach the patient while viewing the red reflex and approach closely. And from here, you can ask the patient to look straight ahead with relaxed gaze. This by this approach, you can see the optic disc first. Although it may not be as good the first time when you're approaching a patient, it will take time, but it's a very good tool to start with ophthalmoscopy. In the red reflex, as on the left, this is the normal view, whereas on the right, we can see at times we can get a dark opacity. It can be because of the lens or any pathology of the vitreous, where we can check it with the movement of side to side. We ourselves have to move slightly side to side, and we can see where it is located, whether in the lens or the vitreous. Now, wherever we use the condensing lenses, moving ahead from direct ophthalmoscopy towards slit lamp and indirect ophthalmoscope, head-mounted indirect ophthalmoscope, first, the field of view is directly proportional to dioptric power, and magnification is inversely proportional to power of the lens. To get the best out of your condensing lenses, it is really important that you keep your lenses clean, free of fingerprints and oil marks, and scratch-free by using microfiber cloths while cleaning. Slit lamp binocular direct and indirect ophthalmoscopy may be done with the contact lenses with coupling agent like Goldman. In this, we have 3 mirrors, which apart from the central view, which can give a good view of the posterior pole, the first one, the tongue-shaped, can give the details of the angle of the anterior chamber. But then we have the middle size that is about 63 degrees inclined and give a good view of the ciliary area. And the longer one, which is angled at 73 degrees, that can give a good view of the aura. Here are some of the lenses which are commonly used above, which is 78 and 90D, where the magnification is as mentioned with the field of view and can be used for the purpose of general screening and small pupil. The good point about 60D lenses is that it gives a good view of disc and macula and does not need to be multiplied by the factor for an approximate idea of the size of various landmarks and lesions. The slit lamp binocular indirect ophthalmoscopy requires us to place the patient stable on the chin rest. You can ask someone to hold the head in place with the forehead gently resting on the headrest. For holding the lens, the good technique is to place between the index finger and the thumb, and while the other 2 fingers are 2-3 fingers are free, you can hold up the eyelid and brow so that you can combat eye closure and also in patient of ptosis. Here is the alignment, which would be an achievable target ideal position. For the indirect ophthalmoscope, we get the inverted image. As you can see, if you are examining the right eye, a direct ophthalmoscope may give this kind of image. Contact lens used in slit lamp biomicroscopy can give this image, but as soon we use a non-contact lens in the slit lamp biomicroscopy or head mount IO, we get a completely reversed image. That is, your up is down and the left is right. Now, how do we combat this problem on a slit lamp? So first, we can remember when we can ask the patient to move his eye towards right so that we can see the right side of the retina. So like here, we have the right eye. When we ask the patient to look towards right, we can see the temporal side. And similarly, when they look towards the left, we can see the left side. Another factor which is changing and what can be changeable is the place of the condensing lens. So you have to ask the patient to keep the eye steady, and keeping the slit lamp steady, we can move the condensing lens towards the right so that we can see the right side of the retina, being the right eye. And when we use the condensing lens moving towards the left, we can see the left or the nasal side of the retina. Last, when we move the slit lamp and keeping the other, that is condensing lens and eye in steady position, as soon we move the slit lamp to our right side, we see patient's right retina on the right side, that is temporal. And similarly, if it is left eye, towards the nasal side of the retina. The vice versa is explained in this image. For slit lamp settings, keep magnification to 10 times. Vertical light beam is preferable of 5 mm height and 2 mm wide. Coaxial alignment is good way to go. Ask the patient to look at the ear in front of their nose. Example, if you're right eye of the patient, you can ask the patient to focus towards your left eye so that you can get a good view of optic disc. That should be the aim. The light reflex centered between the pupil of the eye to be examined is essential, and maintain that position of the slit lamp to vertically align yourself and pull the slit lamp towards your own self fully. Then see the condensing lens has image of whole eye upside down. Place it in a way like that, and then visualize red reflex. Tilt the lens so that you can combat any glare that is coming in your way. And then move the slit lamp and lens consequently forward one at a time to focus, then refocus whenever it is blurring, ultimately fitting the entire retinal image into the rim of the condensing lens you're using. Next, we move on to the head mount indirect ophthalmoscopy. It gives a good view of 60 to 90 degree at once. Now, with the movement of your own head, the lens, and patient's eye, along with indentation, you can look up to the aura with a good stereoscopic vision. So here, when the light beam from the indirect ophthalmoscope passes through the condensing lens, it hits the retina. Then we get an aerial image, which is received by the two prisms of the indirect ophthalmoscope bilaterally, further crossing the eyepieces and into the observer's eye. As it has been discussed earlier, I won't go into the parts of the ophthalmoscope, but it has to be kept very carefully so that you can use it for the purpose in a good and long way. Otherwise, it is very easy to get damaged if fallen or handled carelessly. So what all awaits to be seen in clinical fundus examination? First of all, there's media. It can be clear, but when it is blurred, every finding is important. And then we can go on to optic disc and macula and fovea and the posterior pole, retinal vasculature, background, and peripheral retina up to the aura. Media can be hazy and vitreous haze can be graded. So towards here, we have a clear image which is appreciable. And as we see the blurring advancing, it has a scoring system where +1, +2, +3, and +4 are the grades, where +4 where we don't get any view of the posterior pole. Vitreous hemorrhage can be fresh or old. The fresh one is rich in heme, and the old one is having heme absorbed and looks bit whitish or to yellowish. The important findings of the media as vitreous seeds, asteroid hylosis, and syncytial may look similar, but with close observation and age group of the patient with presenting symptoms, it can be very important to save a child's vision, eye, and life. First of all, vitreous seeds, it is dispensed from the retinoblastoma and contains calcium. Further, if we see this, we can plan a B scan, which gives high A spikes. And then going on to asteroid hylosis, these can be seen as cholesterol lipid deposits, and it is calcified and mostly seen in the older age group. While movement of the eye, it may show movement, but it always comes back after a great amount of movement to the place in the vitreous. Syncytial, it is lipid-rich bodies, and similarly, we have syneresis also, which signifies collagen frame breakdown. Next, in the posterior pole, we have macula, but before that, how to make optic disc present to you. So in direct ophthalmoscope, you can ask the patient to gaze in a straight direction with relaxed eye. Then you can go close to the patient with the right eye aligned to the patient's right eye while using the right hand holding the direct ophthalmoscope. With this and with practice, you can definitely see the optic disc appreciated well. Then in the slit lamp assisted binocular indirect ophthalmoscope, you can ask the patient to look at your ear as I discussed earlier. Finally, with the head mount ophthalmoscope, when sitting, you can go for the same with the patient looking at your left ear when you are seeing the right eye. And when lying supine, it is good to ask the patient to look straight up ahead on the ceiling, and you can have a good direct view. And if you're still lost, catch any branching point and move in the direction of arrow. You can never miss the disc in this way if you have good clarity. So here, if you start at the supero-temporal side, see it is pointing towards this side. Then the next branching point, find the next branching point, and you go according to the next branch as seeing it as an arrow. Next branching comes over here, and accordingly you can go all the way here to the optic disc and appreciate it well. What all we do see in optic disc and note are first that it is of orange or salmon pink color. It might be pale with chalky white, dirty gray, or waxy appearance. Then also we can appreciate sometimes angry red disc, which is hyperemic and also called as hot disc in cases of inflammation. Then, after the color and shape, size can be appreciated well with the 5-degree aperture in Wells-Allen, which amounts to 1.5 millimeter aperture size. On an average, this can be of 1.6 to 1.7 vertically of the outer rim. Okay, and then slit lamp bio with plus 60D lens. Whenever we are using, we don't have to factor in the magnification correction factor for accuracy of the measurement of the structure we are seeing. The disc may be larger in myopes and smaller in hyperopes, which can give a wrong concept about what the CDR is actually and whether it is glaucomatous or not. So what is CDR? It is the cup disc ratio vertically. So vertically, the cup extent can be demarked by where the vessels are bending to the nearest and compared with the disc on the denominator side. So this has to be for uniformity compared in the vertical diameter. Now, when we see the ophthalmoscopic view moving side to side, we can appreciate a good stereoscopic view of the retina. 0.3 to 0.5 is somewhere close to the average cupping we can see. Although in children, 0.5 can be bothersome. Bilateral difference of more than 0.2 is significant. So always have a comparative view of the right and left eye. Myopes, as I mentioned earlier, may give a false high cupping and may look like a glaucomatous cup, but you always have to see the vessels, whether they are losing the entire cup to the sieve entirely sinking down as the cup gets degenerated, which is totally formed by the retinal fiber layer. Also, the hyperopes show crowding of vessels, so the cup disc ratio may be low. One more finding which we can appreciate with the hyperopes can be confusion with the papilledema, which is bilateral, or disc edema we can mention when it is unilateral edema of the optic disc. So here what happens is that the cup margins are not seen at all, and the amount of dioptric change can be measured by using the direct ophthalmoscope and quantifying the progress of the edema itself without treatment, and with treatment the regression of the edema here. The cup disc ratio at this point should be documented as non-assessable. The history with this kind of finding should be taken much in detail and reviewed as the factors I have mentioned here in the slide. The neuroretinal rim is the next part which we have to give attention to, where this is between the cup margin and the disc margin. The thickest being the inferior, then superior, the nasal side, and thinnest at the temporal side. As you can see, normally it is like this, and when there is glaucomatous change, the inferior notching is most commonly appreciable as in the diagram. The RNFL defect, where the notching is, can be appreciated with the red-free filter, and accordingly we can also see perimetry changes in the same area. Alongside, we have to look for any disc hemorrhages which can be indicative of a notching. There, RNFL defect, it is a very good prognosticating marker for progressive visual field defects in future and beta zone peripapillary atrophy. Use concentric grid to mention wherever the splinter hemorrhage is or RNFL defect is for the future documentation. Optic disc, as we can most oftenly see, can be well placed in a good plane, whereas in some cases we can see temporal nasal superior or inferior tilts. Recently, a very good paper has been published where progressive disc tilt was associated with the development of RNFL defects in children who were myopes with a large cup disc ratio. Finally, the blood vessels where the Castenbaum's index is 10, that is exiting and entering vessels at the disc margin have to be counted. If less, it signifies atrophy up to 7 or 6. If high, it can go above 10. Spontaneous venous pulsation can be appreciated in maximum of the population. When seized, it is a marker of raised IOP or because of raised ICT. Although absence does not completely signify it if in case the patient has already had no venous pulsation at all, which is physiologically possible as well. Now coming to the macula and fovea, we have to see the foveal reflex, which is because of the umbo, and which is
Sorry to interrupt you, ma'am. Requesting you to wrap up as we are short on time.
sure. Then the status of the vessels, the course and structure. Above the lesions which can be seen in the macula, the border of the lesions have to be defined. Look for any hemorrhage, any scarring, and elevation or defect at the place. So here are few of the cases. We can see abnormalities in macula. This is an edematous central foveal place. There we can see a CSR. The macular hole can present like this, and we have a Watkey-Allen test where the patient sees a broken line when shown a slit. There can be deposits, which can be hard exudates or drusen's with overlying vessels, and here above with bright yellow and faded yellow color. The macular hemorrhage can be appreciated in wet ARMD, for example, and finally CRAO by seeing the cherry red spot or metabolic disorders in there as well. We can see commercial retina. At the first bifurcation, we have to check AV ratio, which is normally 2:3, and AV crossing changes have to be seen in form of any nicking. We also have to see whether the vessels are tortuous, also any intraretinal microvascular anomalies, or NV in the form of fan-shaped angry vessels. Peripheral retina cannot be missed as there can be retinal lattice degeneration, holes and tears which may look innocent but can lead to retinal detachment. One tip, whenever you are seeing through the rim in the indirect ophthalmoscope, you see the periphery towards the part of the rim which is closer to you. Documentation is important in the Amsler-Dubois chart, where the first concentric line shows signifies equator, then your aura, and finally where the ciliary processes are. Practice on reti and convert clinical photos to drawings in training and get it checked with your seniors, specifically faculty, so that you can get better at it. It can also be integrated in EMR, and fundus photography is definitely a good imaging device, but Dr. Fechner has said once that I'm warning not to use those devices instead of a careful examination. The technology complements what we can see, it doesn't replace it. So from here, I wish you all happy exploring and thank you for your kind attention. due to paucity of time, I may have missed important points for which I ask the panelists to please add on. Thank you for the opportunity.
Thank you. Thank you so much, ma'am. That was very comprehensively covered. So I would like to ask two questions to the panelists. One is going backward and one is going forward. Going backward first. So I feel like direct ophthalmoscopy is, when I joined as a resident, it was just after the first wave of COVID. So we were sort of discouraged from doing direct ophthalmoscopy because since we have to get very close to the patient. And I finished my residency in 2023. And to be very honest, I'm not very comfortable doing direct ophthalmoscopy. So do you guys feel that, it's a forgotten skill, or like, does it still hold a place in our current practice? And second would be going forward, since we have non-mydriatic fundus cameras available now. We have optos, we have scleras, and a lot of practitioners are sort of, supplanting clinical fundus examination with fundus imaging. So what is your take on that particular thing? Probably Dr. Kairobi ma'am, would you like to answer first? Like your comments on that?
Sorry, I was a little distracted just now. See, the thing is that the direct ophthalmoscopy has its advantages. See, this is the first instrument that we learn on generally in all the hospitals. That's the first instrument, and that's easy as compared to the indirect ophthalmoscope. So the thing is that yes, you have to go close to the patient. You have to see, I mean, you're very close to the patient, but it has its own advantages because you get a direct view. There is no like sort of reversal in your mind or whatever of the images, how it's supposed to be. And the thing is that the macula and the disc are seen in a good amount of magnification, and you can sort of see in certain situations it's invaluable because when you're trying to get hold of the depth of the CD ratio or the depth of it, whether there is papilledema, no papilledema, means optic nerve changes and minute changes around the macula, which you become more conversant with later when you go with the indirect. And it's easy because it's a binocular view. But a direct ophthalmoscopic examination is a must, and every person who is aspiring to be an ophthalmologist has to learn this technique first, because you build from basic to more advanced things. And see, the thing is that the direct ophthalmoscope also has its advantages when you're doing evaluations for eccentric fixation or central fixation. The grid is there, which you're not able to do with the indirect ophthalmoscope. So I don't think it should be a forgotten art. It is something which has to be incorporated and learned first. Yes, the indirect ophthalmoscopy takes its time. There's a learning curve for this, and when you start with the indirect, you first learn to focus to get your priorities right. Okay, that this is the temporal is actually the nasal and the nasal is temporal, and the inverse image which comes up. You get used to that, and then when you come on to your scleral indentation, you have to tell the student that it is going to take about a month of regularly doing it to master the this of seeing peripheral lesions through depression, because it depends on the eye type. Because if the eye is very small and I mean, or it's sunken, it's much more difficult to do this kind of an examination than in a case where the eye is prominent, myopic, where it is more easy, where you may able to even see it without the depression. So these are few things which are important, but I don't think that you can sort of avoid the direct scope, because that has its advantages for many indications.
Can I make a comment?
Yeah, please, ma'am.
Yeah, a very nice talk, Dr. Sonam. Regarding the direct ophthalmoscope, I think it's a skill every undergraduate should know, because you need to do bedside. Suddenly, you need to go and take a call on a head injury patient or a patient in the gynec ward. Do they have disc edema or not? couple of years ago, I was asked to come to give an opinion in another hospital. And I myself was, thinking, oh my God, I'm going to do a direct ophthalmoscope after more than 3 decades. So I think it's something we shouldn't lose track of when we, especially those of us who go into retina, because we take the indirect so much for granted that I think it's important for these bedside examinations. And I think it's a skill I learned as an undergraduate, and I think everybody needs to know it. It's not exclusively for PGs. Once you are a PG in ophthalmology, I think you need to know your indirect well.
Thank you. Thank you so much, ma'am. Dr. Apurva, your take on digital imaging, fundus imaging, sort of supplanting clinical fundus examination.
Yeah, that's a very interesting question, Samir. Definitely, the threshold for imaging has really reduced because even the smallest of pupils, optos can give some view. Like if there is an uncooperative child, a 2-year-old or rowdy 3 to 5 year old child, very boisterous, you're not able to this thing. Yes, you need to hold the child down and kind of try to see through maybe a not very dilated pupil, but a little cooperative child or even somebody who can just position well, you get very nice images in small pupils. And Optos has really kind of helped and gone a long way in examining fundi which probably would not be seen clinically. I think a lot of us would agree, especially like posterior synechiae and uveitis, not allowing the pupil to dilate at all. Opto still gives some clue of the posterior segment inflammation, even if it is just to show a swollen disc. That is very valuable for us to know how inflamed the eye is, whether it's just anterior uveitis or there is a posterior segment inflammation as well. Uh, Also, it has become very easy now. I think as we are getting more and more digital, we are getting lazier and sloppier with our clinical examination. But it's always important to be conscious of the fact that nothing can replace a good indented peripheral examination. Optos cannot give you obviously, till the aura. So we have to do all our examinations clinically and use the digital platforms or the photography systems only for patients or cases where it is impossible to do a clinical examination. I think we have to see these cases firsthand and then use them as a supplementary tool rather than trying to replace it.
Thank you, ma'am. Dr. Karogi, or any other comments, ma'am? You would like to add anything?
I mean, just an example. See, the thing is that nowadays in this era of social media, etc., people will send you all their images on WhatsApp and ask you for your opinion, Doctor, is this manageable? What is the kind of visual gain you will get when such a patient is operated? I mean, they send you pictures of scans and then they'll ask you these kind of questions. See, generally, what do? We never answer these questions. We always check the patient first. Okay. So that is a simple answer to the question that you're asking, that however good the photographs or the images are, it can never, never replace a good clinical examination where you personally have seen all the facets that you need to see before opening your mouth to give an opinion to anybody. So I think I that's the take that I would like to sort of emphasize on.
Thank you. Thank you so much, ma'am. Thank you so much, Dr. Sonam Verma, for your talk. With this, I would like to invite our next and the final speaker for the session, who's Dr. Ashreya, and she'll be talking on basics of OCT angiography. Over to you, Dr. Ashreya.
Uh, Thank you, Samir. At the outset, I would like to thank EIOS for this opportunity to present in front of this esteemed panel. And no better person than MPP ma'am to teach us more about OCT angiography. So, good afternoon, everyone. I have no conflict of interest to declare. So the presentation will follow this format. So first I'll discuss a little about an introduction, give a little introduction about the OCT angiography in brief, how it is done, the physics behind it. Following that will be the uses of OCTA, then the interpretation, how you interpret a good OCT angiography, OCTA findings in typical retinal conditions, and to end it, we will talk about a little about the, sorry. Can you see my screen?
Yeah, your screen is visible. We are currently on contents.
Okay. So, and then we'll move on to the artifacts which are seen in OCTA. So, OCTA follows the principle of diffractive particle movement of moving red blood cells to determine vessel location through various segments of the eye without the need for any intravascular dyes. It's non-invasive, high resolution, and depth-resolved imaging modality. It captures volumetric data, which allows for a layer-specific localization of retinal pathologies, including structural and blood flow pattern in tandem. It can be described similar to an ultrasound, which generates images using time delay and light echo magnitudes, and provides a high contrast image of retinal and choroidal vasculature that is amenable to quantification. More recently, it offers the capability to identify and characterize biomarkers which are important for clinical practice and therapeutic research. So, with the plethora of investigations that we currently have, do we really need an OCT angiography? So, OCT angiography provides a 3D visualization of the retinal and choroidal vasculature. It's high speed with a full scan obtainable in a few seconds. There is no need for a dye injection. We're able to segment the retina into different layers, that is, it is depth encoded. And we have a superficial inner retina, the deep inner retina, the outer retina, which is normally avascular, and the choriocapillaris layer. Now, if we compare an OCT angio with the FFA and ICG, we do know that OCTA is non-invasive, it is captured in a matter of seconds, it is dye-less, the resolution is very high. And with the ability to actually locate the pathology, the on-fast segmentation of layers is possible. However, having said that, the OCTA cannot be replaced, cannot be used to replace FFA or ICG, because as we all know, artifacts are very high in OCTA and it's difficult to interpret an OCTA in the presence of these artifacts. And no matter what, the pattern of leakage, such as pooling and staining, which we see on FFA and ICG, cannot be determined on an OCTA. So moving on to the uses of the OCTA is used for research into pathogenesis of diseases, disease quantification, and treatment evaluation. We can isolate locations of vascular pathologies, analyze each retinal vascular plexus separately, evaluate the foveal avascular zone in detail, examine the perifoveal endocapillary area, examine the retinal microcirculation, and evaluate response to anti-VEGF therapy. There are numerous indications for OCTA in today's day and age, but most commonly we use it for diabetic retinopathy, wherein early detection and monitoring of microvascular changes, including capillary non-perfusion and detection of microaneurysms, can be done even before the appearance of clinical symptoms. It also plays a very important role in ARMD for detection and monitoring of choroidal neovascularization in dry and wet AMD, allowing for timely intervention to prevent vision loss. In retinal vein occlusions, it identifies areas of capillary non-perfusion, macular edema, and the development of collateral vessels or neovascularization in cases of BRVO or CRVO. The other indications include in glaucoma, where we can assess the microvascular changes in the ONH and the peripapillary region for diagnosis and monitoring of glaucoma progression. Macular telangiectasia, CSR, uveitis, retinal vasculitis, and myopic CNVM are the other important indications. Hereditary retinal dystrophies, ocular ischemic syndrome. It's very important in a patient who has an OIS because it is useful to identify and monitor the worsening of ischemia in a patient who has ocular ischemic syndrome. The other indications are Coats disease, IPCV, tumors, and nowadays it is very useful for post-surgical monitoring for the retinal and choroidal blood flow to look for retinal regression of neovascularization, especially after procedures such as vitrectomy or retinal PRP lasers. So what are the systems which are used for angiography? We use a time domain system and a Fourier domain system. So the Fourier domain system is what we basically use now because it is more helpful as the speed of acquisition of image is very high. In that we have the spectral domain OCT and the swept source OCT. They are the two types of Fourier domain OCTs which are used for performing the OCTA. Now the Fourier domain OCT is a technique that further enhances the speed and sensitivity as compared to the time domain system. It uses a spectrometer or a wavelength swept light source to measure the intensity of interference signals over a wavelength range and obtain an interference pattern. So this results in high speed and highly sensitive measurements without unnecessary noise. So to break it down simply, a light beam is split into a test beam and a reference beam to generate the OCT images. The light from the test beam hits the tissue and it undergoes various modifications like refraction, attenuation, reflection, comes out different from the eye, from that which went in the eye. It is then cross-referenced with the reference beam, and the machine then analyzes the differences and the images generated. When this generates A-scan images, when multiple A-scan images are compiled, we get a B-scan image. Further compilation can be used to create a three-dimensional image. So when the difference between two scans is picked up because of the movement of the RBCs, what we get is a decorrelation signal, which forms the basis of the image, and this mirrors the vasculature of the retina. So what are the wavelengths which are used in OCTA? So we have a 840 nanometer wavelength, which is used in SD-OCT, and a 1050 nanometers, which is used in the SS-OCT. With the SD-OCT, it's low cost, it has a good resolution. However, there is more attenuation of signal due to media opacities, and the beam is visible to the patient, so there's more chances of eye motion and artifacts. As compared to that, the 1050 nanometers, which is used in the SS-OCT, has a better beam penetration, so it's very useful in a patient who has a dense cataract, and the beam is not visible to the patient, so chances of eye motion artifacts are less. So OCTA uses motion contrast to detect blood flow in the retinal and choroidal vessels. It captures repeated B scans, that is cross-sectional scans at the exact location, and flow information is extracted by detecting changes between consecutive scans. So this process allows for the creation of detailed en-face images of the microvasculature. The scanning process itself takes only a few seconds. So OCTA typically captures scans at different retinal and choroidal layers, including the superficial vascular plexus, the deep vascular plexus, the outer retina, and the choriocapillaris. The machine also automatically segments the retina into these layers for further analysis. So how to interpret an OCTA? Now the OCTA is becoming increasingly popular among clinicians due to the ease of acquisition of images of the retinal vasculature. However, it is important to realize that even a great image will not provide any relevant information unless it is interpreted correctly. So the basis of interpretation is understanding the vascular supply of the retina. It is important to analyze it layer by layer or slab by slab, depending on what pathology we are suspecting. Always correlate with the structural B scan and the en-face images, because that provides a more multimodal and whole interpretation. And it's always useful to analyze the video because it decreases the chances of artifacts. Interpreting the artifacts. So just a brief overview of the circulation. So we have the vitreous, which is avascular, the superficial retinal plexus, the deep retinal plexus, which is from the INL to the ONL, the outer retina, again, which is mostly avascular, and the choriocapillaris and the deeper choroid. So this is a color-coded B-scan OCT. The structural OCT is depicted in grayscale, and the retinal and the choroidal circulation is in red and yellow, respectively. So the superficial capillary plexus extends from the internal limiting membrane to about 9 microns over the IPL-INL junction. There is a deep vascular complex which extends from 9 microns over the IPL-INL junction to 9 microns below the OPL-ONL junction. This in turn is made of the intermediate capillary plexus and the deep capillary plexus. The intermediate capillary plexus is from 9 microns over the IPL-INL junction to 6 microns below the INL-OPL junction. And the deep capillary plexus is from 6 microns below the INL-OPL junction to 9 microns below the OPL-ONL junction. So the intermediate capillary plexus is not seen in most of the machines. There are very few machines which actually give us the intermediate capillary plexus, but it is supplied by the arteriolar branches which are coming from the superficial capillary plexus. The venous outflow of the ICP and the DCP, it forms a single axis that drains into the vein of the superficial capillary plexus. So each layer has its own unique architecture and distribution, which is very important to keep in mind when we are interpreting the OCTA. So what does a normal OCTA look like? So there are 4 slabs which we mainly concern ourselves with. That is the superficial and the deep capillary plexus slabs, the avascular, and the choriocapillaris. So the superficial capillary plexus is like a spider web. So it appears as a fine homogeneous capillary network, and we can see that the perifoveal arcade can be seen all around. The deep capillary plexus is more close-knit network of vessels, and it's also present all around the FAZ with numerous horizontal and radial interconnections. The avascular layer, as the name suggests, is avascular, and the slab is taken 110 microns above the RP to 60 microns above the RP. The choriocapillaris is a homogeneous grayish slab which is composed of tiny dots that are either hypo or hyper intense, and there are no vascular channels clearly detectable. So what are the components of an OCTA report? This is a typical OCTA report which is obtained from the SSOCT. We have the particulars of the patient. It's very important to see the name, the date of birth, and the signal strength when we're interpreting the report. What is the area of the scanned section, whether it's a 3x3 or a 6x6? Which eye is being scanned? The other slabs? The main angiogram that we're looking for, the corresponding en face image, and the corresponding structural OCT-B scan. Now, when we look at the scan, what do we look for and where do we look for it? Unless we know what we're actually looking for, we don't know where to look. So if we are looking to identify retinal vascular diseases, it's important to look at the superficial and the deep capillary plexus. Whereas if you're looking to identify choroidal or neovascular lesions, we have to look at the ORCC or the avascular slab. Now, there are 3 patterns of abnormalities which are seen on OCTA. One, there can either be abnormal presence of new vessels, as seen in a CNVM or a neovascularization. There can be an abnormal vessel structure and orientation, such as dilated tortuous vessels or microaneurysms, seen in a retinal vascular occlusion or a diabetic retinopathy. There can be an absence of flow, that is a capillary non-perfusion or a capillary dropout, which is seen in a proliferative diabetic retinopathy or a retinal vein occlusion. Now, the most common clinical conditions that we encounter, such as diabetic retinopathy, can be either NPDR, PDR, retinal venous occlusions, retinal and choroidal neovascular membranes, or a MACTEL. So I'll just be touching up briefly on these. Coming to diabetic retinopathy, now OCTA is very helpful to detect DR even before it is clinically evidenced. So this is an image of a non-proliferative diabetic retinopathy with the focus on the macula. We have a FFA and the corresponding OCTA image. On the FFA, we're able to see that other than the appearance of a few microaneurysm and a fairly distorted FAZ, we're not able to get too much information. However, when the corresponding OCTA is analyzed, the superficial capillary plexus shows that there is a distortion and enlargement of the foveal avascular zone. And the deep capillary plexus shows there's a loss of vessel wall density with an enlargement of the deep capillary plexus. So even before it is clinically evident, OCTA helps us to detect DR by noting an increase in the size of the FAZ. There's a decreased parafoveal vascular density and a decreased flow density at the DCP. Now, these factors, they help us not only to determine the severity, but also to prognosticate the patient and, give an idea about how the vision is going to improve even after, if the patient needs anti-VEGF or any treatment. So this was a patient with a proliferative diabetic retinopathy. We can see a large leaking neovascularization superior to the arcade, but the exact details are quite fuzzy because, of the intense leakage which is visible. Corresponding OCTA image which was taken shows a nice neovascular complex with a single trunk and extending branches. This patient then underwent a panretinal photocoagulation, and the FFA image that we obtained after that shows that there is a regression of the new vessels, which was confirmed on the OCTA. And but it is important to note at this juncture that the laser marks that are visible on the FFA will never be visible on an OCTA, and the capillary non-perfusion areas will always persist even after regression of the neovascularization. So Whitefield OCTA this is a Whitefield OCTA showing gross NVD and VE with extensive capillary non-perfusion areas. And it is easy to interpret this superficial capillary plexus slab because it very closely resembles an FFA. Coming to a vein occlusion or a retinal vascular occlusion. Now, any vascular disease is difficult to assess the foveal microvasculature because of capillary network superimposition and leakage, which is seen on FFA. Now, the OCTA, it allows demonstration of the foveal avascular zone enlargement, capillary non-perfusion, microvascular abnormalities, and vascular congestion. So this image shows a vein occlusion with cystoid macular edema, which is seen on the structural B scan. The superficial vascular plexus shows extensive capillary non-perfusion areas, which when we go deeper and see the deep capillary plexus, we can see that the ischemia is much more and is more marked congestion in the DCP. Again, helps in prognosis. So this is a case of a central retinal vein occlusion where, in spite of having no macular edema, the patient kept complaining of poor vision. The FFA did not give us much information other than a few fuzzy leaking spots around the macula. But when we did an OCTA and examined the superficial capillary plexus, we could see that there was an enlargement of the FAZ with a reduced vascular density in the deep capillary plexus, indicating macular ischemia. This is again a wide field OCT of a peripheral branch retinal vein occlusion. The superficial capillary plexus shows these capillary non-perfusion areas, but when we examine the deep plexus, there is a further extension of these non-perfusion areas, indicating that any vascular pathology is more severely affected the deep plexus as compared to the superficial plexus. Coming to a choroidal neovascularization, so this patient had come with a dense cataract and a poor vision. Clinical examination revealed that there was a CNVM at the macula. We went ahead, did a fluorescein angiogram, which did not give us too much information. The structural OCT revealed a nearly scarred CNVM. I wanted to look at this image on the right here. We went ahead and did an OCTA, and we can see that a network was picked up on the OCTA. However, point to be noted is that when we segmented the section properly, we were able to see that there was a very large network which was picked up, which was otherwise would have been missed because of this improper segmentation. So segmentation to line the exact layers is very important if you want to pick up the extent of the network. Also, the presence of this halo around this network indicates that it is still active and there is still leakage going on. So it prudence treatment. Again, this was another patient who was detected with a type 2 CNVM. The FFA does not really give us too much information other than fuzzy leakage near the macula. But the OCTA helps us pick up a proper network, which helped us treat the patient early with injections. A type 3 CNVM or a RAP is a retinoretinal anastomosis, which again is picked up very well on an OCTA because we can see the vessels dipping into the surface of the retina. Now, CNVM secondary to a CSR again is the OCTA plays a very important role because in a chronic CSR with sick RP, the FFA does not give us too much information other than the fact that there'll be just fuzzy leakage without any specific CNVM picked up. But when we do an OCTA in such cases, the network is picked up beautifully and it helps us differentiate it from just a CSR with sick RP and treat it accordingly with injections. So this OCTA again shows regression of neovascularization. You can see the network here. The patient received injections and there was regression of the network. So it's a useful tool to monitor the progress. Another important condition is MACTEL, that is idiopathic juxtafoveal telangiectasia. When we do a FFA in such patients, we're not really able to get too much information because there is just generalized leakage around the macula. But an OCTA gives us an exact depiction of the vascular structure, especially if we are suspecting a CNVM in a patient with a MACTEL. With proper segmentation, we are able to pick up the network and then treat it with injections. Coming to the artifacts in OCTA, there are a wide range of artifacts, but I'll just touch upon the most important ones. We have the pupil vignetting artifacts, defocus artifacts, motion artifacts, shadow artifact, projection artifact, and artifacts from segmentation. So what are pupil vignetting artifacts? So when we see a dark shadow at the edge of the scan, which is seen in all the slabs, this is known as a pupil vignetting artifact. It means that the light entering the eye is not entering fully. It is bouncing off the edge of the pupil, which is casting a shadow. And it is important to differentiate it from a pathology is because one, it's seen in all the layers. So that's how we know that it's because of it's an artifact and not a pathology. Defocus artifacts where the machine is not focused properly, the small vessels will appear blurred. There'll be reduced flow signal, dim structural OCT image. There'll be a lower signal strength index, and it can be seen in astigmatism, higher order aberrations, and dry eye. The motion artifact is mostly related to eye movement and correction of the eye movement on part of the machine. So fast motion can leave residual artifactual flow signal, especially on bright structures such as the RPE. It appears as 2 or 3 bright lines on the on-fast OCTA, and larger microsaccades appear as disjointed blood vessels, as we can see here. So these lines, they are motion artifacts, and microsaccades can appear as disjointed. There'll be interruption in the blood vessels. The other artifacts include so vessel doubling. Because of motion correction technology, some vessels are seen doubled side by side. There's lateral displacement of the vessels, and there is a smear artifact where 2 images combined of the same area are seen at the edge as stretched or smeared. So a shadow artifact again is quite important. Basically, the flow signal is dependent on reflectance signal from which it is derived. So if the OCT beam is blocked by retinal structures or opacities in the media, there will be dark regions on both the OCT and the OCTA, almost similar to the shadows that we see on a fundus fluorescein angiography. The causes of focal shadowing include large retinal blood vessels, vitreous opacities, hemorrhages, drusens, hard exudates, and RP detachment. The RP defect causes a focal brightening of the reflectance and the flow signal. So it's important to correlate with the on-fast and the structural OCT, and it helps identify and rule out shadowing. So this is an example of a shadow artifact. The purple areas that we see are areas of normal perfusion. The green arrows are areas of hypoperfusion, caused by disease. The blue arrows, areas of hypoperfusion caused by shadowing, most probably vitreous. The yellow arrows on the ONFAS and in the OCT show vitreous opacity as the cause of the shadowing. And the red arrows show intraretinal fluid as a cause of the shadow artifact. Another important artifact is the projection artifact or decorrelation tails, as they're often called. So when moving blood casts flickering shadows, which are interpreted as flow on OCTA and appear bright. These artifacts can be visualized on both cross-sectional and on ONFAS angiograms. On ONFAS, there is a replication of the superficial vasculature on the deeper vasculature. Examination of ONFAS OCTA slab of the superficial and the deep layer together helps us to identify these artifacts. So this is how a projection artifact looks like. The figure A, this is the superficial capillary plexus slab. So when we look at B, that is the deep plexus, we can see the superimposition of the superficial capillary plexus. With proper segmentation, when we remove all the superficial and the deep plexus, we can see that neovascularization appears, which was otherwise not visible when we were looking at the superficial and the deep slabs. The other way projection artifacts can appear is when there's perception of flow which is occurring at levels other than where the original vessels are located. For example, projection artifacts from retinal vessels on drusen's with no choroidal neovascularization can produce images which look like CNVMs. Also, when you have a large PED, the edge of the PED on the B scan, it generates a false positive decorrelation signal on the OCTA image. So it's important to make sure that we differentiate artifacts from true new vessels. So segmentation artifacts, again, pathologies that distort the retinal layers can cause errors in automatic computer segmentation. So these artifacts can be identified using assessment of the cross-sectional scan with segmentation overlaid on the structural OCT. Manual correction of these poor segmentation can resolve these errors. So in this picture, we have a patient who has got RPE atrophy, and the machine automatically segmented it, resulting in the appearance of a network which was otherwise not there. So when the segmentation error was corrected with proper segmentation, we can see that there's no network, and it was just because of the appearance of layers from underneath. So just to summarize, we've gone through all these artifacts, and it's important to make sure that these artifacts are taken care of or ruled out before interpreting the OCT. So where do we stand today as far as OCTA is concerned? As with all other investigations, OCTA has its advantages and limitations. It's an excellent tool to detect areas of ischemia and non-perfusion. It's a great modality to image the DCP and the radial peripapillary capillaries, which is not possible with FFA. It avoids the complications which are associated with the use of intravenous dye for imaging, and is useful for detection of diabetic retinopathy even before it is clinically evident. But not all is hunky-dory. We are unable to still visualize vessels that have no flow or flow which is slower than the detection threshold, unable to visualize leakage, as in a leaking CSR. There's a limited field of view. It is dependent on accurate retinal segmentation for visualization of vessels. Multiple artifacts make interpretation difficult, and there's always need for correlation with a structural OCT. And it often detects networks which don't require treatment. That is a quiescent network. So it's important to correlate with the patient's symptoms and the clinical findings. So what are the key takeaways here? So OCTA is a very important and useful diagnostic tool. It has revolutionized the imaging of retinal vasculature as it's non-invasive and can be repetitive. It provides high contrast image of retinal and choroidal vasculature that is amenable to quantification. We should know where to look for what. It is important to interpret the OCTA by examining each slab in order to not miss any pathologies. It cannot be used in isolation and does not overthrow conventional dye-based imaging techniques or a thorough clinical examination and correlation. Always compare with the structural OCT to check for activity or leakage. And most importantly, beware of artifacts. These are my other references. Thank you.
Thank you very much, Dr. Ashra Karpe ma'am, for the simplified presentation of a rapidly evolving modality such as OCTA, its working principle, and its clinical relevance. I would now request our esteemed expert panelists to share their thought and perspectives regarding the use of OCTA. Dr. Purva ma'am, would you like to chime in?
Thank you so much, Doctor, for that very nice presentation, Dr. Ashreya. You actually put in a lot of effort to show cases from your actual practice. It was good. Really nice to see. So my favorite indications for OCTA are where I would really heavily rely on an OCTA would be macular ischemia. If there is some edema, but it's not explaining the drop of vision, or the vision is not correlating with the level of edema in diabetes, I would definitely want to look at the FAZ, and sure enough, we will find a lot of dropout in the superficial and the deep capillary plexus. We have to beware that the segmentations do not pass through the optically empty spaces of the cystic edema, and something that lies outside of those having a proper dropout is indicative of ischemic maculopathy. My next indication would be something which was dry AMD for a very long time, develops an elongation of the flat irregular PED. We think it is a drusenoid PED which has elongated or something, but when we do an OCTA, we find a network. Even before the fluid comes up, there is evidence of a network. When you look back to the older OCTAs of that patient who developed a new onset exudation in dry AMD, you can see evidence of those small networks that had appeared even before the fluid, obviously. Then my next indication is for MACTEL, especially for fellows, like teaching points would be whether the fluid that is SRF that is seen, a degenerative fluid that is seen in earlier stages of MACTEL that have not developed a neovascular membrane yet, versus a CNVM due to MACTEL. So the abnormal capillaries would be circumferential or in the MACTEL area, but a CNVM would look very different on the OCTA. It's important to make the distinction between whether it is a MACTEL CNVM with fluid or it is just fluid, degenerative fluid seen in earlier stages of MACTEL. Then another very important indication which you showed also is the chronic CSC patients who develop a pachychoroid neovascular membrane. According to many studies and in my own personal experience, pachychoroid neovascular membrane is best seen on OCTA and not on FFA ICGA because of the early washout from these membranes. So they fill up fast and they empty really fast. So on a dye-based angiography, they are seldom caught. So OCTA is a very good modality to detect these quiescent pachychoroid neovasculopathy membranes. Then one more thing that I have seen that we tend to call Shrem a scar many times based on their appearance. If it's a well-defined subretinal hyperreflective material, it is very organized and it has these more acute angles. We tend to call them scars and don't treat many times. But if we find some disorganization and we suspect that the Shrem is because of an active CNVM, OCTA will definitely show a difference in the appearance of the membrane. The membrane can be a dead tree in a scarred Shrem, but then there will be some areas in the tree with active activity, with a perilesional halo, having this cartwheel appearance of these closed loop that we see. It can be there even in a dead tree. So these patients may have that Shrem pocket inside an organized Shrem, which is suggestive of an active CNVM, although the OCT can misguide us as it being a scar. So these patients we have to treat despite us thinking that it's a scar based on OCTA. These are some from the top of my head, some things I like to look at OCTA for in my daily practice.
Thank you, ma'am. Karubi ma'am, would you like to add?
My only thing is that apart from Apurva has very nicely sort of listed out a lot of things, but it's also its advantages in where you're trying to monitor a patient whom you've been given intravitreals, especially the more recent intravitreals, where they have a longevity and a duration, where you're doing a PRN kind of a treatment. So if you want to monitor that once, there are sometimes some cases don't recur for months on end, but I think it is important if we get an octa and we get a very kind of fluorine new vessel which is uh, lying there. It is better to inject earlier than wait for it to really break forth, and then you start the treatment afresh. And that was one point. And second is that I just wanted to ask people who are regularly doing octas on their own that where segmentation is concerned, do you think a 3 by 3 slab would be better than a 6.6 for segmentation? And what would be the kind of pathology where you would like to have a thin segmentation or a thick segmentation? Because I don't have an octa, I send it to someone to get it done. So I just want to ask people who regularly do it, what would be their take on this?
Muna ma'am.
Una?
Dr. Muna ma'am, are you here with us?
Yeah, very much
Yes.
here. There's a little background noise. I was trying to mute it. Can you hear me?
We can hear you.
Yes, ma'am.
Yeah. Okay. So now your question was on the segmentation. The most important part is when you're doing a high myo for a patient with RP atrophy or where the choroid is very thin. So that's where the importance of your segmentation comes in, because you're likely to get artifacts due to the large choroidal vessels and the choriocapillaries which are shining through. So that's when you need to segment your slab very thin. So that is important of the segmentation slab. Now, as far as the size of the scan is concerned, if you are looking for a CNVM or you're looking for macular ischemia, the most dense scan is a 3 millimeter scan. So if you're really looking for a small CNVM or you're looking at MACTEL, then a 3 millimeter scan is good. If you're looking at diabetic macular edema and you're not looking at very fine details, then a 6 millimeter scan is okay, which is the standard. But if you're looking for, say, neovascularization in PDR, then the wide scan is important, the 12 millimeter or the montage. You center the first scan on the macula, then you center the second scan on the disc, so that you don't miss the nasal ischemia or neovascularization. But it's important to know that wide scans take time. So if patient is not going to be cooperative, then you won't get a good image. So your best images of a wide scan are when they have very good vision, clear media, and they are able to comprehend and follow your instructions. Yeah.
Thank you.
Thank you, ma'am. One question from my side for the panelists. How do OCT angiography and FFA complement each other in routine practice? In which clinical conditions would you recommend evaluating both the modalities together to arrive at the accurate diagnosis? Apurva ma'am?
To answer that, yeah. So, Mahima, nice question. One very clear indication would be maybe ischemic maculopathy in diabetic retinopathy. That's the one for me. See, because in CNVM and other things, we hardly do FFA ICGA nowadays, unless you want to prove that there are polyps on ICGA. Even that, the APOIS has given us very clear-cut, beautiful definitions on how you can detect polyps just on OCT. So for me, if you ask me that question, where FFA and OCTA would complement each other and would clinch the diagnosis, and if you want to maybe avoid anti-VEGFs in a case of severe ischemic maculopathy, which is also again debatable, then that is one condition where I would take them both together. Other than that, I can't think of anything. If you want for academic purposes, you can do, if you're doing a study, you want to see if there is something like MACTEL, for example, if you want to see focal hyperfluorescence apart from the diffuse hyperfluorescence, or you want to do an OCTA in, say, choroiditis, and you see these flow signals on the choriocapillaris slab, that will, the flow voids that you see on the choriocapillaris slabs, like for example, APMPP or serpiginous choroiditis or your MFCs, these have very clear-cut flow voids on the choriocapillaris slab on OCTA. If you do an FFA in these cases, or an ICGA especially, it's easy to differentiate between CSC, stromal choroiditis, and choriocapillariopathies. So that is one more place where OCTA will be really valuable in combination with the invasive angiography. But I don't do many FFAs unless I want to do something like I want to add some more information. But I don't see any reason why we need both, you know.
Also,
Can I
if
add to
you
that question?
do multimodal
Yes, ma'am.
imaging, then you can sort of correlate it with the kind of areas which on an ICG show are hypercynosins, and if there are void areas which are there, which after treatment you find it filling up. So it gives a good monitoring for your when you want to show the case and the kind of improvement that you're effecting with the steroids. It generally helps in these kind of situations.
Una ma'am wanted to say something.
Yeah, I would probably add to that cases of CSC, because sometimes you can get leakage and you get CNVM. You're not sure what exactly is the cause of the fluid. Probably there is a role for FFA and ICG still in these kind of cases. And also, if I'm not sure, you have a very elderly patient and they are a little apprehensive about anti-VEGF therapy, and it's a very small area, you're not sure on OCTA, then I probably would ask for an FFA or an ICG just to make sure that I'm justified in offering them treatment.
So basically, OCTA helps us to define the anatomic disturbance at a microscopic level. And with FFA or ICGA, we can see the physiological disturbance with leakage and all.
Also, I think another condition I really like to do FFA along with an OCTA is in ocular ischemia, because I like to base my lasers on FFA, and then the progression of the ischemia can be monitored easily with the OCTA.
Thank you, ma'am. So, as we come to the end of this session, I would like to extend my sincere thanks to all the speakers.
On a lighter note, Apurva, come again, show yourself.
Yes, ma'am.
Yes. I think you need to look for your left earring.
I know. It's there, it's down. It fell off. Thank you.
Okay.
Okay, so I would like to extend my thanks to all our speakers for their excellent presentations and to our experts for enriching the discussion afterwards. Before we sign off, a quick reminder for everyone, session number 14 for Retina will continue this evening from 6 to 9. We look forward to all the viewers to join us again for another engaging and educational session. Thank you once again. Have a great day ahead.
Well conducted, both of you, Samir and Mahima, and all the speakers were excellent. Thank you so much. We enjoyed ourselves.
Thank you for having me.
Thank you,
everyone.
ma'am.
Thank you, ma'am and sir. Thank you.
Enjoyed this.